and audio both.
Yeah.
Bye. See you, sir.
Bye.
Bye.
Shall I start?
Manish has come. Manish is.
Hi. Hi,
Ma'am, we
Manish.
are live now. Good to go.
Right. Good evening, everyone. Myself, Dr. Sonal Mehta, Lead Medical Advisor in TAS. INTAS, in association with Iraq Fertility Society, have organized this teaching module on infertility and USG. I welcome you all to the fourth module of this teaching program. Today we have with us the eminent faculties, Dr. Manish Banker and Dr. Jatin Shah with us. Dr. Manish Banker is Medical Director, Nova IVF Fertility and Pulse Women Hospital, past President ISAR, recipient of Professor B.C. Roy Award 2018, Chairman Infertility Committee, FOXY 2007 to 2010, Regional Representative International Committee Monitoring ART, Member Surveillance Editorial Board IFFS, Founder Board Member Aspire, Member Draft Committee for ART Bill ICMR, Member of Board Poseidon Group. And with this short introduction, I welcome Dr. Manish Banker, sir.
Thank you.
Before we start the session, I will also introduce Dr. Jatin Shah, sir. He is specialist ART, MD, DGO, gold medalist, Director Mumbai Fertility Clinic IVF Center, dedicated to the treatment of the infertile couple and instrumental for establishing more than 15,000 successful IVF pregnancies. Helped to establish the first IVF ICSI pregnancies in UP, co-authored textbook Photographic Atlas of Gynecology and OBGY Techniques in his student days, award for Best Paper Presentation in National FOXY Conference, award Young Personality of the Year 2003, pioneered the setting up of centers in Cochin, Agra, Madurai, and various centers in India, and more than 500 national and international presentations, guest lectures, keynote addresses, and orations. He's founder member of Aspire and published original research papers on GCSF and much more. This is a short introduction of Dr. Jatin Shah. I welcome Dr. Jatin Shah, sir.
Thank you. Thank
And
you.
today we also have with us Dr. Salama from Baghdad, Iraq. She is Vice President, Baghdad, Iraq Fertility Society. With this, I request Dr. Salama to welcome Dr. Manish Shah, sir, and Dr. Jatin Shah, sir.
Good day for everyone. On behalf of Iraqi Fertility Society, I'd like to thank the well-known NICE company of INTAS for their organization and arrangement of this beneficial course. And I want to say thank you for faculty and consultants for their time and for sharing us their experience. So thank you.
So now Dr. Manish Shah, sir, Manish Banker, sir.
Okay. Okay. Thank you very much for this kind introduction. And it is a pleasure to be a part of this very good initiative put forward by the Iraqi Fertility Society and Intas Pharmaceuticals. This is my second engagement with you, and I shall today be talking about pre-assessment, that is pre-IVF assessment, who needs IVF, what exact pre-IVF workup should be done, how do we test ovarian reserve, and very brief about the drugs and protocols before my co-faculty, Dr. Jatin Shah, takes you in detail about various stimulation protocols. So what I will be covering is what is ART, who needs ART, what are the prerequisites, how do we do the pre-ART workup of a couple, something about ovarian reserve testing, and very brief overview on various drugs and protocols. Now, ART or assisted reproductive technology includes all fertility treatments in which both the sperms and the eggs and the embryos are handled. In general, This will involve surgical removal of eggs from a woman's ovaries, combining them with sperm in the laboratory, creation of embryos, and then returning them either to the woman's body or vitrifying them or use them for donation. So you have numerous processes in this, beginning with IVF, ICSI, with the use of donor sperms, with donor eggs, or with donor embryos, or surrogacy. And even though IUI is generally clubbed as a part of this is strictly not ART because the oocytes are not collected in the process of IUI. So IUI is the process of artificial insemination where we put a concentrated motile sperms through the cervix into the cavity of the female partner around the time of ovulation. And the aim of this procedure is to place this concentrate of motile sperms as near as possible to the egg and as close to the time of ovulation as possible. IVF or ICSI is a more advanced procedure where fertilization of the egg takes place outside the human body in the laboratory, that is in vitro, and hence it is called in vitro fertilization. The embryos are created and these are then transferred back into the uterus a few days later. Now, in the conventional IVF procedure, these eggs are put together earlier in a test tube, hence the name test tube baby, but nowadays in a 4-well or a petri dish, and they are left to fertilize on their own. In this, some of the eggs may not be fertilized, more so if the quality of the eggs or the number of sperms is very low. In ICSI or intracytoplasmic sperm injection, each mature egg that is retrieved is injected artificially under magnification with a single sperm to improve the chances of that egg getting fertilized. Now, in general, before we move into who should be offered IVF, an important breakthrough to understand or point is that the duration of infertility and the chances of normal conception are very directly linked. And as a couple becomes, or the duration of infertility becomes longer and longer, the chances of natural pregnancy becomes lower and lower. So if a couple is married for a period of 1 year, then beyond that, the chances of pregnancy in 1 month drops to 8%. And after 2 years, it drops to 6%. So whatever success rate that we see for IVF or ICSI, this should be reviewed with this particular background as to by how many times are we able to improve the pregnancy rates. Remember, nature has given us a pregnancy rate of 20% only. So the indications of couples who would be offered IVF or ICSI, I'll put IVF ICSI together to begin with, could be divided into male related issues or female related issues, or it can also be divided as IVF ICSI as the first line of treatment or as a second line of treatment following other procedures like an IUI. So let us see, when do we offer IVF following an IUI? Primarily when the total motile sperm count is more than 1 million, but it's less than 10 million, that is, there is mild to moderate degree of oligospermia, or in certain indications in the female, for example, when there is a unilateral tubal block, mild to moderate endometriosis, especially in young women, or the primary problem is anovulation, or in couples who have got unexplained infertility. In all this scenario, generally the couple is offered a few attempts at IUI before moving into IVF. However, IVF is offered as the first line of treatment, or ICSI primarily, when the total motile sperm count is less than 1 million, or there is severe teratospermia, or there is azoospermia, which could be of obstructive or non-obstructive variety, where we are retrieving sperms either through epididymal aspiration or a testicular biopsy, or when there is complete asthenospermia, that is all sperms are immotile, or when there is severest form of teratospermia, a condition called globozoospermia, where all the sperms lack the acrosomal cap, and hence none of the sperm is able to fertilize the egg on its own. It is also offered as a first line of treatment when for the tubes you have a double block, that is the tube is blocked at two places, a cornual and a fimbrial, where you would not even resort to a tubal surgery, or large hydrosalpinges which have destroyed the tubal mucosa, or tuberculosis which has destroyed the tube, extremely short tubes, or when the tubo-ovarian relationship is altered, or when the woman has severe endometriosis, has poor ovarian reserve, premature ovarian failure, advanced stage, or when there is need for some form of genetic testing, or if she needs third-party reproduction, which I shall be discussing in my second session later on. So even in these cases where IVF is not the first choice, one should also look at the time interval to pregnancy, because by offering IVF, we are able to shorten the time that the woman would take to achieve pregnancy. And typically, if IUI is performed first, a maximum of 3 cycles of IUI is recommended, because beyond that, the cost benefit ratio drops. But for an IUI, we need at least one patent fallopian tube. And when we are looking at this time to pregnancy, one should also look at the age of the patient. Does she have this longer time? Does she have the luxury of this time? So then let us review individual factors and see at what stage would IVF move into its treatment algorithm. Now, tubal disease generally accounts for about 10 to 20% of female factor infertility, and a large majority of this is due to some form of salpingitis. We also know that nearly 20 to 30% of women who undergo tubal ligation as a part of family planning end up regretting the procedure and come back for having another child. So what the ASRM guidelines mention about tubal factor is that before you decide as to whether to offer this patient surgical correction or move into IVF, we need to look at multiple factors. Age of the patient, ovarian reserve. Older the patient, lower the ovarian reserve, the algorithm shifts more in favor of IVF. Has she conceived earlier or not? How many children does she desire? The local disease and its extent, presence of additional fertility factors. The couple could have tubal factors with oligospermia. And the two most important considerations being experience of the surgeon in carrying out tubal surgery versus the success of the ART program available. And lastly, we should also pay heed to patient preference, religious beliefs, and cost and insurance reimbursement considerations. So keeping all this into account, you would then decide as to whether you would offer surgical correction, either laparoscopic or laparotomy, or you move into IVF. Now, IVF offers certain distinct advantages when you are treating tubal factor. And the main advantage is that the per cycle success rate, the last data we have is the US registry of 2015, at 32% live birth rate, which is fairly superior than any other treatment. It is less invasive, and in general, the per cycle success rate is higher than tubal surgery. So the ideal candidate for tubal surgery is a patient who is young, who does not have any other infertility factor, and has a problem in the tubal anatomy, which is easily amenable to surgical repair. This is a good paper comparing IVF versus tubal surgery. And what this concludes, even though this is a very old paper of 1995, it still concludes that more than 70% of women with tubal factor infertility will end up with a live birth within 4 cycles of IVF treatment. No tubal surgical procedure offers such high live birth rates. So these results of IVF compare favorably with the best possible outcome of tubal reconstructive surgery. Another area which is important amongst tubal factor is hydrosalpinx. And I'm talking about a hydrosalpinx, which is either visible on ultrasound, something like this, or on a laparoscopy shows the tubes completely tortuous, very typical hydrosalpinges. Now, there is data available that in women who have hydrosalpinx with non-hydrosalpinx tubal factor infertility, the odds ratio of a pregnancy are higher with other non-hydrosalpinges factors. There is also evidence that if you do a salpingectomy before carrying out IVF, the pregnancy rate jumps from 18% to 30%. This is all the more important if the hydrosalpinx is bilateral, there is an increase in success rate. If it is ultrasound visible, the success is still more pronounced. And if the hydrosalpinx is bilateral and ultrasound visible, removing it leads to a remarkable increase in jump. So if the patient of a tubal factor has an ultrasound visible, more so bilateral hydrosalpinx, one must resort to salpingectomy after proper counseling before you proceed to IVF. The same thing that has been concluded in this Cochrane review, that the option of laparoscopic salpingectomy should be considered for all women who have hydrosalpinges and are due to undergo IVF. I then move on to the next category of patient, and these are another large chunk, women with ovulatory dysfunction because of polycystic ovarian syndrome or rarer conditions like hypogonadotrophic hypogonadism. Here, the primary problem is anovulation, and it is typically with 3 to 6 cycles of ovulation induction alone or later on with IUI. However, if the patient has advanced stage, if there is presence of other infertility factors, then moving into IVF would be better, because IVF, apart from being therapeutic, also gives us information on the quality of the eggs. So in a woman with PCOS, ART is indicated if they are refractory to ovulation induction, or they do not conceive after multiple cycles of ovulation induction, or if they have coexisting pathologies like severe male factor, tubal factor, endometriosis, or have advanced stage or a prolonged duration of infertility, or they need additional pre-implantation genetic testing. So the evidence summaries recommendation, these are from the International Evidence-Based Guideline. What this suggests is that in a woman with PCOS, you begin with lifestyle intervention. The first line of pharmacological management is then either letrozole, clomiphene citrate, without metformin or gonadotrophins. The second line of management includes either gonadotrophin or laparoscopic ovarian drilling. And when all these fail, you would then move to IVF. So IVF is typically used as the second or the third line management in patients with PCOS who are essentially young. The third area that we need to look at from the female point is endometriosis. And one moves into IVF in a woman with endometriosis if there are peritubal adhesions, if the endometriosis is recurrent, if she has poor ovarian reserve, or she has undergone long-term ovarian suppression. So in general, young patient with grade 1 or 2 endometriosis, she is treated as a woman having unexplained infertility, but grade 3 or 4 or with advanced stage, one moves directly into IVF. And the last category are those patients who have unexplained infertility. And here the algorithm begins with a few cycles of ovulation induction, a few cycles of IUI. You repeat whatever investigations that are necessary, and you look at the cost-benefit ratio, especially keeping in mind the age of the patient and the duration of infertility. Because older the woman, longer the duration of infertility, shorter should be the time devoted to simple ovulation induction and IUI. From the male aspect, certain conditions are only amenable to IVF or ICSI treatment, and that is presence of obstructive azoospermia. The commonly because of congenital bilateral absence of vas deferens. You can do any of these surgical retrieval techniques per epididymal sperm aspiration, testicular sperm aspiration, testicular sperm extraction, or an open testicular biopsy. So ICSI becomes the first line of treatment when you have complete asthenospermia, that is 100% immotile sperm. What you need to do is identify a sperm which is alive but immotile and see whether with the help of vital staining whether you have motile sperms. But while you are doing ICSI, you do a hypoosmotic swelling test. That is, you put the semen in a hypoosmotic solution. And if the sperm is alive, the sperm membranes would be functional, and this will allow this hypoosmotic fluid to move into the tail, leading to coiling of the tail, and you can then select that sperm to perform ICSI. Or it is offered when there is severe teratospermia, where you could select the very few normal sperms that are present to perform ICSI. Or when there is consistent, persistent, severe oligospermia, less than 1 million on multiple attempts, usually combined with astheno and teratospermia as well, wherein you would directly move to ICSI. Because one must remember that even though you are performing ICSI for a male factor, ultimately the success and the cost of ART is dependent on the wife's age. So when treating male infertility, keep a very close eye on how old the woman is and how good or bad her ovarian reserve is. Once we are sure as that we are offering IVF to a particular couple, let us then move into the various prerequisites that are necessary before you start any of these ART procedures. On the male, we need certain very basic tests like a blood group. You do a blood count to rule out any other obvious problems. You do the full serological markers, and you do a sugar screening to rule out diabetes. You also do a proper semen analysis before you start the treatment. And if the patient has persistently low count, one should counsel about the benefits of doing karyotyping. It is a common practice in most ART units to cryopreserve one semen sample before starting treatment. This is helpful if the husband is not available when the treatment is happening, is it traveling, is in business travels, or sometimes when is unable to produce a semen sample on the day of the procedure, this cryopreserved semen sample can be used as a backup sample. The requirement of sperms as far as an IUI is concerned is between 2 or preferably above 5 million per ml after process. For IVF, you need approximately 50,000 sperms per egg that is being inseminated, whereas for ICSI, it is as low as it can get, and that is 1 sperm per mature egg. One should consider a proper andrology consultation if there is persistent oligoteratoasthenospermia or when there is presence of sexual dysfunction. In a couple having azoospermia, sometimes you do a trial testicular biopsy to be sure that you will be able to retrieve sperms and you are not left without any sperms on the day of egg collection. And if it is a very, very borderline case, we must counsel the couple from the beginning as to if adequate sperms are not retrieved on the day of the egg collection, would you be willing for the use of donor sperms, or would you like to vitrify your oocytes and then decide as to what to do with this particular oocytes? As far as the female partner goes, the investigation is slightly more complex and thorough. You repeat the same test, but you be more diligent because you need to be sure that this patient is also fit to become pregnant. So you measure the hormones and you also do a thalassemia screening. You should also measure her BMI because this will help you in deciding the stimulation protocols. You do a pap smear as a part of your general gynec examination, and if not a mammography, at least a proper local examination to rule out a breast pathology. In certain instances, you might require a medical physician's opinion, especially from the point of suitability for anesthesia, or even fitness for pregnancy when we are treating older women in their late 40s for the process of egg donation, or when you're treating surrogates, where you need to be more vigilant from their fitness. We then move on to assessing the two critical aspects. One is the endometrium, and second is the ovarian reserve. For the endometrium, you should do a proper pre-ovulatory ultrasound scan. If it is normal, then we don't need anything further. But if it is abnormal, either the thickness is very low or when the echogenicity is poor, then you might need to resort to additional investigations like Doppler or procedures like hysteroscopy with or without a biopsy. In women who are anovulatory, poor ovarian reserve, or have premature ovarian failure, you will have to do this endometrial assessment after giving them estradiol because their endometrium in an anovulatory cycle will not proliferate. We then do a proper pre-treatment counseling. This should include all details about the procedure, the cost, and an accurate prognosis for that particular couple. And we then make them sign a consent form after giving them full explanation to both partners carried out in front of witnesses. And this consent should be in accordance with the national laws and guidelines. Let us then move on to the actual workup of the couple. And we will look at three things: the semen analysis, the role of sperm DNA fragmentation index, and looking at the endometrium and the ovarian reserve. The aim of this is first to find out whether the patient is amenable to ART treatment or whether she will require something else like adoption or donor insemination. So as a part of your general examination, you do complete history taking, you do a detailed physical examination, and I covered this during my first talk on investigating and examining an infertile couple, and you do a proper semen analysis. This should either be collecting the semen with masturbation, or when there are problems, you use a condom which does not have spermicidal gel so that these sperms can be used to carry out IVF or ICSI. And you classify the semen based on the latest WHO manual. These are the various terminologies, and this is how you would define. We also take the relevant male history, important about history of mumps orchitis or cryptorchidism or genital trauma. You do a proper physical examination, especially if there is presence of azoospermia. Now, DNA fragmentation index is a test to determine the integrity of the sperm DNA and see whether it is intact or it is fragmented. This is helpful in couples who have history of recurrent miscarriages, who have been exposed to agents which can lead to DNA fragmentation like smokers or high oxidative stress, repeated urogenital infections. And if the DFI value is less than 25%, then it is considered as normal and we do not do anything. If it is high, we should correct the pathology or give antioxidants or resort to other spatial sperm segregation procedures like MAX or PIXI. Now, the endometrium needs proper assessment prior to starting of the IVF treatment, because no matter how you create the embryo, whether you use the husband sperm or donor sperm, husband egg or donor egg, ultimately you have to transfer the embryo into her uterus for successful implantation. And you could resort to conventional 2D ultrasound, use color Doppler, or use hysteroscopy very judiciously. So morphologically, the endometrium is the most dynamic target tissue in the woman because it changes its structures cyclically, and it is regulated by both ovarian hormones, the estrogens and the progesterones. And a thin endometrium or the endometrium is one of the most sensitive indicators of the hypothalamo-pituitary ovarian axis. So what happens in the endometrium is, in the follicular phase, it gradually keeps on growing in size till the date that it reaches ovulation, and it subsequently turns receptive and ready for implantation. So this is how the post-menstrual endometrium looks. It is like a thin line. As the endometrium is exposed to estrogens, it starts to proliferate into this classic triple line echogenic pattern. Post ovulation, it loses its echogenicity and there is posterior enhancement. So when you assess the endometrium before IVF, you look at the endometrial thickness and you try to rule out any endometrial pathology. For most patients, a standard two-dimensional ultrasound, which is simple, is enough to measure all these basic pathologies. Now, 3D ultrasound is helpful when you want to especially rule out uterine abnormalities, or you want to better delineate the presence of any intrauterine pathology. Now, when you measure the endometrial thickness, it should be measured in the sagittal plane along the longitudinal axis at its thickest point. If you are resorting to, or if there is presence of an abnormality, this is an arcuate uterus or this is a septate uterus. In a 2D scan, you can see the polyp here. This has been reconstructed in the 3D scan. You could also add color to this and look at the endometrial blood flow right up to the endometrium and see whether the blood flow reaches right the basic layers of the endometrium. So as the 2D ultrasound does not allow quantification of blood flow in the endometrium, the combination of power Doppler with ultrasound was thought to be a breakthrough as it allowed the objective of both invasive and non-invasive visualization of the endometrium. However, when we look at most of the publications till now, it has been shown that even though 3D power Doppler ultrasound is useful and effective measure for assessing blood flow, it is probably not necessary in each and every patient undergoing IVF, because many studies have shown that it does not provide additional information, or it is time consuming and it does not have consistent results. So the role of color Doppler as a standard pre-IVF investigation to determine endometrial receptivity is not yet standardized. So this is a publication looking at the assessment of uterus in 3D ultrasound before ART, that given the inconsistencies in the studies published to date and the additional limitations of reproducibility, 3D ultrasound assessment of the endometrium and the subendometrial vascularization is not recommended for routine practice in a normal ART setting. Having said that, it is probably one of the best tools to assess uterine abnormalities. All types of, whether it's a T-shaped cavity, septate, a unicornuate, or a complete bicorporeal. So for diagnosing uterine abnormalities, 3D ultrasound is extremely helpful. We then move into what is the role of hysteroscopy before starting IVF. If there is an obvious abnormality on 2D ultrasound, hysteroscopy becomes a must. This could be a polyp or a submucous fibroid. But the question is, if we have normal 2D ultrasonography, is a hysteroscopy mandatory for every patient before you start an IVF procedure? And this is a very large trial called the Trophy trial, hysteroscopy in recurrent IVF failure. And this study concluded that outpatient hysteroscopy before IVF in women who have a normal ultrasound of the uterine cavity does not improve the live birth rate. So in the absence of any obvious abnormality, a routine pre-IVF hysteroscopy is not mandated. So the evidence still now suggests that the best way to assess the endometrium is to monitor one full cycle using 2D ultrasound. If an abnormality is suspected, 3D ultrasound will help. In patients where she is not able to achieve an adequate thick endometrium, you could supplement with estradiol and then do the monitoring. And in presence of an obvious pathology, you must do a diagnostic cum therapeutic combined hysteroscopy. We then move on to the last area, and that is testing the woman for her ovarian reserve. Now, we all know that every woman is born with a fixed number of oocytes, and this is called the primordial follicle pool. This is highest between 16 to 20 weeks of intrauterine life. At birth, it has already significantly dropped to around 1.2 million. At puberty, this further drops to around 300,000 oocytes only. And a woman typically loses 400 eggs during 400 ovulatory cycles in her adult reproductive life. So what is then the ovarian reserve? So ovarian reserve is the available primordial follicular pool that can be stimulated if the patient is subjected to proper ovarian stimulation. Now, this could be the pool of primordial follicles, but for an IVF, what we are typically looking at is the gonadotropin responsive follicles, that is the committed follicles that are available, or the cohort available for that particular cycle. That if this cohort is stimulated, how many of them could we be able to stimulate and rescue from the process of atresia? So ovarian reserve is a term to describe the functional potential of the ovary. It reflects the number and the quality of oocytes, and it refers to the remnant in the declining primordial pool or reflects the reproductive potential of each ovarian stimulation. Now, there are two major predictors of ovarian reserve. If you want to look at the quality, it is our age. If you want to look at the quantity, we have various ovarian reserve tests. Age, something which is very often ignored, is the single most indicator of a fertility potential. And a woman's fertility starts declining from her late 20s or early 30s and decreases further after the age of 35. So while a woman who at the age of 20 and a woman at the age of 40 approximately ovulate for approximately the same times in a year. So this woman of 20 years will also have 12 ovulatory cycles in a year versus this woman at 40 who will also have the same 12 ovulatory cycles in a year. Their monthly pregnancy rates will be vastly different because of the difference in their oocyte quality. And this is a paper which shows that with advancing age, there is a decline in the number of ovarian follicular reserve. We have also published that the ovarian reserve is dependent on the ethnicity. And Indian women, and this could possibly be true for other Asian women also, that the ovarian reserve of Indian women declines 6 years earlier than their Spanish or Caucasian counterpart. So this suggests that there are also ethnic differences in ovarian reserve. Let us then see what are the tests available, and I shall focus only on the ones which are of clinical relevance. Now, biochemically, you have the anti-Mullerian hormone, FSH, estradiol, and inhibin B. You could use ultrasound, the antral follicle count, or the ovarian reserve, or you could do a provocative test like the clomiphene challenge test. Now, what is AMH and why do we measure AMH? Now, this AMH is a homodimeric glycoprotein. The specific expression pattern of AMH in growing but non-selected follicles has prompted investigators to see whether this is indicative of the size of the growing follicle. However, we cannot directly measure the AMH from this primordial follicular pool. So what we are doing is an indirectly measuring from the growing follicles. So this AMH is primarily secreted by the gonadotrophin independent primary and secondary follicles, and this is probably the best indicator of what is left in the ovary. So it is secreted by this primordial, primary and the preantral follicles before it reaches the state of gonadotrophin dependence. The advantages of this is, one, there is very low intercycle variations. AMH measured in 3 different cycles, very little variation, whereas for FSH, the variation is higher. The confidence intervals are much lower in this. Second, it can be assessed at any day of the cycle with a single variation. And you can see that the variations in AMH are extremely low as compared to that in FSH. So 2 advantages. First, it can be measured on any day. And 2, there are very little intercycle variations. Having said that, it also has its own variation. And this is primarily reflected by 3 things. It's biology, it's the exposure, and the laboratory test that has been used. And if only one is affected, the variable is very low. Whereas if all the 3 sources are affected, you could still have larger variations in the AMH values. So what does impact the variation in AMH is the BMI, the ethnicity, vitamin D status. You could have polymorphisms of AMH and its receptors, or maybe genetic variations, or currently even smoking has been associated with lower AMH levels. So it is fairly constant, but not as constant as one would have liked it to be. It can be collected on any day of the menstrual cycle. In the normal range, anything below 0.7 nanogram is called diminished ovarian reserve. And one should also remember that there is some evidence coming in that in women having endometrioma, but with no prior history of surgery of endometriosis, the AMH levels increase with the size in ovarian endometrioma. The second way of measuring the ovarian reserve is to look at the antral follicles. Now, antral follicles are small follicles of below 10 millimeters in size. And what you do is total up all the follicles seen in both the ovaries. So this ovary, let us see, has one here, whereas this ovary has multiple 1, 2, 3, 4, 5, 6. So you measure all the follicles which are less than 10 millimeters in size in both the ovaries and you add them up. So we are looking at all the follicles that are available in both the ovaries. Now this is indicative of the relative number of the small primordial follicles remaining in the ovary. And how do you say whether it is normal or not? So a normal antral follicle count, the combined total in both the ovaries should be in 2 digits. If it is between 5 and 11, it suggests a lower ovarian reserve. Whereas if the total antral follicles are less than 4, it suggests very poor ovarian reserve. And if it is more than 30, it points towards polycystic ovarian syndrome. So AFC alone, if you do on the third day of the cycle, it accurately predicts the number of oocytes that can be retrieved in that particular cycle, because this is the cohort available at the beginning of the cycle. There are again very low fluctuations in the antral follicular size, and there is very high inter and intra observer reproducibility. So along with AMH, this is also fairly consistent and fairly reproducible. The only issue sometimes is that there is some lack of standardization, and there is a problem if there are too many follicles. Then it is difficult to count individual follicles, and you now have automated softwares for follicular tracking so that this reduces the inter and intra observer variations. So AMC and AFC are not accurate for predicting a pregnancy, but they are very accurate in predicting the oocyte number or the ovarian response. And this is more so, they are more accurate in predicting poor response. They are also fairly accurate in predicting excessive response. And these two are clinically sufficient. If you measure the AMH and you measure the antral follicle count, this combination is fairly sufficient to determine the ovarian reserve of any patient before you start the IVF treatment. Both along with the patient's age, these three are sufficient markers of ovarian reserve. So age, antral follicle count, and AMH, these three form the mainstay of measuring the ovarian reserve, the quantity and the quality of eggs. And the technologies are improving to measure both the features. Some studies have also looked at the ovarian volume, where you measure the length, width, and the depth and multiply it by 0.4, 0.5. And if the volume is below 4 ml, it indicates low ovarian reserve, but it is time consuming and it does not add more information than the antral follicle count. So to summarize, the dynamic tests are not required pre-IVF. Basal FSH also has very high intercycle variability. AMH is robust. AFC is highly reliable. Age is the cheapest and the most important and the only marker of egg quality. So we need to resort primarily to age, AFC, and AMH. A few words on, do we require any genetic testing before you proceed to IVF? This is primarily for patients who have had recurrent pregnancy losses, or in the presence of consanguineous marriages, or when the karyotypes of the couple or on previous products of conception suggest that there is a problem, or when there is severe male factor, you should resort to genetic testing. And this could be either with a karyotype, FISH, or a array CGH, or an NGS. So what you do in a karyotype is you look at the stained cells under a microscope. This has a very low threshold. You need a higher million base pairs. Or you could move to these arrays, which compare the patient's genome with a reference genome. The advantage of this is that it has a lower resolution array. It is important for POC, and this also helps in identifying balanced translocations. So sometimes in patients with recurrent miscarriages, if you have a product of conception, you should do this low resolution array. And if you find a copy nucleotide variant, then you move to FISH or karyotype. Whereas if the POC is not available, then you do the karyotype for the couples looking for balanced translocations. I will speak for a short or very brief with various stimulation protocols and drugs before we end this session. And this is primarily moving into the physiology of ovulation induction. Now, everything here begins from the hypothalamus. The hypothalamus secretes the GnRH releasing hormone. This hormone is released in a pulsatile manner. It acts on the pituitary, where it leads to the stimulation of FSH and LH, which then acts on the ovary. For the pituitary to respond to this GnRH analog, the pituitary has such exhibits receptors of the GnRH analog. So whenever there is a release of a pulse or a secretion from the hypothalamus, this GnRH binds to these receptors on the pituitary, and it leads to the release of FSH and LH. Once this release happens, this receptors or this GnRH is metabolized and the receptors become free again for the action of the second pulse of the GnRH analog. So you need the analog which binds to the receptor, produces the action. It has to be metabolized and the receptor has to be made free for the second pulse to act so that there is continuous release of FSH or LH. Now, in place of this, if the analog is administered continuously, what happens is that all the receptors become permanently occupied. And if the receptors are permanently occupied, there is no further release of FSH or LH from the pituitary. And this condition is called pituitary downregulation, is that this pituitary is downregulated. It is not sensitive enough. It will not respond by releasing FSH and LH, even if you give the patient further analogs. So when you start the ovarian stimulation for an IVF and you give the patient a GnRH analog, what happens is that the first administration of the analog leads to the stimulation and release of FSH and LH, the so-called flare effect. But as soon as the administration becomes continuous, it leads to pituitary downregulation. As opposed to this, you have the second group of drugs which are called the GnRH antagonists. This also act by help in preventing the premature LH surge, but this causes an immediate suppression without any stimulation, and hence it does not need to be administered in the follicular phase. So these are the two ways of suppressing the pituitary so that a premature LH surge does not happen, so that the patient does not ovulate before the egg collection, and you will not miss out the eggs before you do the ovum pickup. For the stimulation, you then use various gonadotrophins. And what started with the equine gonadotrophins, things have got better and better. The molecules of gonadotrophin have become purer and purer. The technique of producing them has moved from the postmenopausal urine to a complete laboratory manufacture using the recombinant genetic technology. And we have moved from intramuscular administration to subcutaneous to multi-dose injector pens. And the purity and the specificity have kept on increasing. You should also know that LH, so there are two basic types of gonadotrophins, FSH and LH. But LH and LH are very structurally similar and they bind to the same receptors. So you have these various types of gonadotrophins. You have HMG, which has both FSH and LH. It is available either as urinary or highly purified. You have FSH, which only have FSH, which is either urinary, highly purified, or recombinant, or you have LH, which is only available as recombinant. Now, all HMG, even though, as we understand, have equal amounts of FSH and LH, the manufacturing technique has its own limitations that you cannot produce a HMG ampule with equal amount of FSH and LH. The LH component keeps on varying. So to compensate for this insufficient LH in all HMGs, that is spiked with some amount of HCG. And it is this HCG which then has a longer half-life. So any HMG that you give actually has FSH, LH, and varying amounts of HCG. And this is added in the form that 1 unit of LH has about 6 to 8 units of LH activity. And if HMG has typically FSH and LH in equal amount, the more you purify, the more the LH you lose. So you typically keep on adding HCG. And this HCG-driven LH activity is more potent. So when you are giving or treating the patients with only FSH or HMG, this is something that you should remember. As opposed to this, the FSH preparations only have FSH, and based on the degree of the purity or manufacturing, it becomes more and more potent and specific. The other thing one should remember when you are administering the gonadotrophins is, what do you mean by the international units? Why are there variations? So this international units is the bioactivity of that particular gonadotrophin and is generally measured by the Stillman-Pulley bioassay. What is being done is that female rats that are primed with HCG are then administered the gonadotrophin that needs to be measured. The rat is then sacrificed and the ovaries are collected, and we need to weigh the ovaries. And depending on the increase in weight of the ovaries, the strength of the gonadotrophin is decided. So it is a very crude way of measuring the potency. And because of this, the coefficient of variation is very high. Because of this specific limitation of the testing, all pharmacopoeias accept a range of between 80 to 125% as the acceptable range. So any ampule of gonadotrophin urinary origin, when it has been shown to contain 75 international units, could actually have anything between 60 to 94. Whereas if you are using the recombinant measures, which is measured by mass, the measurement is more consistent. And this becomes all the more important when you move into the fill by mass process, because if you're using, or if you're using 225 international units, you could actually be giving 170 or 270. And this is called the batch to batch inconsistency. So then how you decide the starting dose of your patient? You decide it based on her age, BMI, the ovarian reserve test that you have done, and on a response to previous ovarian stimulation. And what is your goal? You aim at achieving something between 10 to 14 oocytes. I shall now speak something about these low prognosis groups, and that is the Poseidon groups. This particular group divides women into 4 groups. Group 1 and 2 are those who have normal ovarian reserve, which means an antral follicle count of more than 5 and an AMH of more than 1.2. Group 1, she is young. Group 2 is old. So group 1 is a young woman with normal ovarian reserve. Group 2 is a woman above 35 with a normal ovarian reserve. Whereas group 3 and 4 are women with poor ovarian reserve. So group 3 is a young woman with poor ovarian reserve. Group 4 is an older woman with poor ovarian reserve. In addition to this, there is also something which is called the patient's response. And when we look at the group 1 and 2, these are the patients who are likely to benefit from all pharmacological intervention because they have a good ovarian reserve. Whereas in group 3 or 4, where the ovarian reserve itself is low, they are unlikely to benefit by change in the ovarian stimulation protocols. For group 1 and 2, there is also 2 other ways of looking at it. And one is the follicular output rate, which measures the consistency between pool of antral follicles and the number of follicles that respond. That means if the patient has 10 pre and 10 antral follicles, when you stimulate, does she produce 10 follicles? If the follicles is correlating well to the antral follicles, then this is good. And second is looking at the consistency between the antral follicle and the actual oocytes retrieved. And if we find that this outputs or both these indices are lower, this suggests a hypo response, and we should either add LH or we should increase the dose. And this is something that will be discussed in detail during the later talks. So you have two ways of preventing the LH surge. Use the agonist or the antagonist. Very brief, agonist you give for 10 days to suppress the pituitary, reduce the dose, and you then stimulate. Short protocol, you start the agonist to make use of the flare effect and you then use the gonadotrophins, or you start the antagonist along with the when the follicle is more than 14 millimeters, when there is a risk of premature LH surge, the early stimulation happens only with gonadotrophins. And I will end by a few slides on how do you program a cycle, or do we need any pre-treatment. You sometimes need to program or schedule cycles for two purposes. One, to improve the follicular recruitment in patients who have a poor ovarian reserve to synchronize the follicles, or it is purely for the purpose of convenience. And there are four varieties of drugs that can be used: on contraceptive pill, estradiol, agonist, or the antagonist. Now, in an agonist suppression cycle, the best way to program is to start the agonist, produce pituitary downregulation. And once the downregulation is achieved, you can delay the start of the gonadotrophins while continuing the agonist for any number of days to achieve proper scheduling. The second way to do this is to put the patient on either a combined oral contraceptive pill or estradiol, and you start it in the luteal phase of the previous menstrual cycle, and you can continue this so that the patient's period gets delayed and you could delay the onset of the stimulation in the subsequent cycle. There is some evidence that using this oral contraceptive pills leads to some amount of pituitary suppression and might lead to a lower ongoing pregnancy rate. Estradiol valerate is one other way of programming these cycles, because this helps in avoiding oocyte retrieval during weekends. You could also give the GnRH antagonist on the first 3 days of the cycles, up to 3 days, and then start the pituitary stimulation. So this also helps you in programming the cycle by a few days. So with this, I have covered the areas of what do you do before you actually start stimulating a woman for an IVF cycle. How do you select a patient? How do you do the pre-IVF workup? What all evaluation you do? What are the various drugs available at your armament? How do you use your ovarian reserve test to select the right drug? I will then leave to my next speaker, Dr. Jatin Shah, who will take you through these various stimulation protocols in detail, and then we open up for discussion. Thank you very much.
Thank you, sir, for giving a very insightful lecture, and I am sure my viewers have benefited with this. In detail, it was a great explanation. I think we will take the questions at last after your second session.
Or we can take, I think questions, we have some time, so we can take, if there are questions, we can finish for this session.
Fine, sir.
We have another 10-15 minutes before we take a short break.
Right, sir. So I will take a few questions. They are asking a patient with PCOS and mild endometriosis. Should we do IUI, induction of ovulation, or should we go for IVF?
I am assuming that this woman is young, but if the primary problem is PCOS and mild endometriosis, you should try ovulation induction with or without IUI before proceeding with IVF. Only if the endometriosis is severe, or if she is elderly, or a very long duration of infertility, should you move to IVF. Otherwise, for such young women, simple ovulation induction is first line. You combine IUI as the second line, and then you move on to IVF.
So induction of ovulation, how many cycles, and IUI, how many cycles should be?
So again, this depends on the age and the duration of infertility, but in general, 3 cycles of ovulation induction, 3 cycles of IUI.
Correct, sir. And for IUI, means induction of ovulation, first line of treatment would be clomiphene or letrozole, and then we move to gonadotrophins.
Yes, yes.
And in IUI, whether it will be directly gonadotrophins, or should we start with this?
So again, this depends on the age and the ovarian reserve of the patient. But if you look at the success rates, clomiphene alone has a success rate of around 10%, whereas gonadotrophins, this goes up to around 16, 17%. So what I generally do is if the patient is very young, the first cycle is with clomiphene. Otherwise, I would always use either a combination of clomiphene letrozole with gonadotrophin or gonadotrophin alone.
Right, sir. And stage 3 endometriosis, as you said, they should opt for directly IVF, or
Yes. Yes,
right,
stage 3, stage 4 endometriosis directly to IVF is the preferred treatment.
correct, sir. And they are also asking, sir, role of ERA.
Okay. So this is slightly outside, but let me give in very brief.
Yeah, sir.
So ERA is called endometrial receptivity analysis. It is a molecular genetic based test where we try to find out the receptivity status of the endometrium in the window of implantation. This is typically used for patients who have repeated implantation failures. It is done either in a natural cycle, that 7 days after the onset of the LH surge, or it is done in a HRT cycle 5 days after the administration of progesterone. And this test will tell us whether the endometrium is receptive, pre-receptive, or post-receptive. If it is pre-receptive, it means the patient needs more days of progesterone. If it is receptive, then it is normal. If it is post-receptive, it means that the patient needs fewer days of progesterone.
Thank you, sir. And uh, you already said that hysteroscopy is not recommended in all patients, pre-IVF hysteroscopy, but when you suspect any intrauterine pathology based on the sonography, then you do the hysteroscopy.
Yes, so in a patient in whom a 2D ultrasound and if required a 3D ultrasound shows a completely normal endometrial cavity, hysteroscopy may not be of value. Having said that, in patients who have repeated IVF failures, sometimes one resorts to a hysteroscopy because very small pathologies could have been missed. But as a routine investigation, before any IVF cycle, hysteroscopy is not mandatory.
Correct, sir. Sir, you also discussed about role of vitamin D and its relation with AMH. So, is there a role of any vitamin D supplementation in such patients?
So this association between vitamin D and the fertility potential is still a slightly gray area, but there is some evidence that vitamin D deficiency does lead to lower fertility potential. And if you find that the vitamin D levels are low, and this is probably more important in places where men and women tend to cover themselves up and they are not exposed to sunlight and they have chronic, very severe vitamin D deficiency, maybe correcting vitamin D deficiency makes sense before you resort to fertility treatment.
Correct, sir. And they are asking that the dose of gonadotrophins means for stimulation will be based on age, AMH, and AFC. Can you, sir, explain by giving any example? How do they go?
I think my next speaker, Dr. Jatin, will be going into this protocol. So I think let us wait for him to.
Right, sir. Right. And another question, one more question, sir. Is FOI, number of AFC and number of oocyte retrieved? They're asking is FOI is related to number of AFC and number of oocyte retrieved. Can you?
So there are two markers. Follicular output rate is the number of follicles in relation to the antral follicles. And follicular index is the number of eggs retrieved in response to the antral follicle. So in one, we are looking at follicles. In second, we are comparing oocytes. And if the number of oocytes is less than 50% of what the number of antral follicles one had visualized, then it means there is a possible hyporesponse. To give you an example, if the antral follicle count of the patient is 12, one would expect somewhere around 10 to 12 oocytes. In spite of appropriate stimulation, if you have less than 6 oocytes recovered, it means the dose that you gave to this patient based on a rentral follicle count was not proper because the woman hypo-responded. And in such cases, you would either increase the dose of FSH or you would add LH.
Thank you, sir. I think we should break for 10 minutes. And sir, it was a very good lecture and with practical tips, and they all are thanking you. I request Dr. Salama to say a few words, and then we break for 10 minutes.
Really, it is very nice lectures and full of nice informations, and it is important for the beginners and for the one who want to start working with IVF. We thank the consultant doctor very much, and thank you.
Thank you.
Thank you very much.
So we will break for 10 minutes, and then we start the next session. Hi, sir. We have given 10 minutes break, so we'll start within 5 minutes or so. Sir, should I take questions after your session or after next session,
No,
Dr.
mine. It'll be too late otherwise.
Yeah. So once you finish your talk, I will take your questions. Okay.
How many online?
I think Sanjeev can say. Sanjeev? It's not. Sanjeev, are you there?
It's okay. It's okay. No problem.
Yeah.
Yes, ma'am.
Sir is asking how many are online, means how many registered.
Okay, okay. Just a second.
Sanjeev?
Sir, total 192 is live, and I'm just checking total registration till now.
No problem. Thank you.
See, this is from, sir, Iraq, Sudan, Baghdad, Nigeria, and these are the countries where these persons are live.
So Sanjeev, shall we start?
Yeah, ma'am, we can go ahead now.
Yes. Yes. So now we'll be moving to the next session by Dr. Jatin Shah sir. He'll be taking us through various protocols, advances in pre-treatment, OHSS free clinic, and all the advances. So with this, I welcome Dr. Jatin Shah sir, and I request Dr. Salama ma'am to say few words.
Yes, we thank the faculties and consultants for to share us their experience in this webinars, and we all attend this, and we will have some questions after the webinar.
Right. So, sir, we can start now.
Yes, sure. Thank you so much, dear Dr. Salama, distinguished delegates, friends from Iraq, Sudan, Nigeria, all our surrounding countries and friends. It's indeed a pleasure to be a part of this educational update online training program. And I'd like to thank Intas Pharmaceutical for this. We have a long marathon session ahead of us for 1.5 hours, and I plan to cover almost every problem that you might be encountering in your daily IVF practice. So, of course, first of all, we have to consider that what exactly are we looking for when we talk of ovarian stimulation. And let's start with this initial slide, where we know that for many years we thought that the optimal number of oocytes that are required for a good IVF pregnancy rate was 5 to 15. And this was, of course, Sankara's classical study, which showed that 5 to 15 is the best for embryo transfer pregnancy rates in fresh embryo transfer cycle. So those were the days before the days of vitrification, when we knew that when you have 5 to 15 oocytes, your pregnancy rates keep increasing with the number of oocytes you have. But once you cross 13 or 15 oocytes, there is a drop in the pregnancy rates because of the supraphysiologic levels of estradiol, sometimes progesterone being high, that causes endometrial advancement, and therefore you would have lower pregnancy rates. But then came the days of vitrification, and now we no longer talk of fresh live birth rates, but rather we talk of cumulative live birth rates. And we now know that the best pregnancy rates are in cumulative pregnancies when you talk of fresh or only frozen plus frozen plus frozen embryo transfers till you exhaust all the embryos which are available. There is an increase in cumulative pregnancy rate until 27 or 30 oocytes, beyond which, of course, there is a plateau because 27 is a huge number of oocytes to retrieve. So there has been a shift in our thinking that we want only 5 to 15 eggs to now wanting 25 to 30 oocytes in the first ovarian stimulation cycle itself, so that you have enough embryos for freezing, so that your frozen embryo transfer and cumulative live birth rates are much, much higher, and the patient doesn't have to go through a painful injected ovarian stimulation cycle again and again. So this is a big paradigm shift which has occurred in our basic understanding of how many eggs are we targeting when we do a good ovarian stimulation. So what are our aims for a good stimulation in 2020? Of course, we want it to be safe. We want our clinic to be absolutely free of OHSS. In fact, a good clinic is only one which is zero OHSS and completely free of any kind of admissions for ascites, pleural effusion, and what many of you might have seen about 5-10 years ago. We, of course, want it to be very effective and successful in that it should give us a good harvest of not only eggs, but top quality embryos. It should be acceptable to the patients. It should be cost effective, especially in the context of our developing nations where cost is still a big issue for patients. And we want just one stimulation cycle, gets 20 to 25 oocytes, have enough top quality embryos for vitrification, and aim for a very high cumulative live birth rate. So that is now our aim of doing a good ovarian stimulation. Of course, we have to divide the cycle into pre-treatment. I'm sure you've already heard a little bit of this before, but I'll try to go more into details into the practical aspects. Then, of course, comes the main ovarian stimulation when you don't want a premature LH surge. So you have to use either an agonist or an antagonist to do that. You want to give the best trigger so that you get a good harvest of oocytes, and not only huge numbers of oocytes, but also a lot of metaphase 2 oocytes, mature oocytes. You then, of course, want to do the pickup. You either want to do a freeze-all or you want to do a fresh embryo transfer, and you want to support the luteal phase. So there are a lot of components that we have to cover today when we talk of good, successful ART treatment. When we look at pre-treatment, a lot of you might still be doing batch IVF where you have a visiting consultant who comes maybe 3 days, 4 days in a month. You need to program your cycles. A lot of you might have used oral contraceptive pills for doing this. What really is the best way to program your cycles? The easiest way to do it, if you have a more or less ongoing program and just want to avoid weekends, is the use of luteal phase estrogen. So all you have to do is give estradiol valerate in a dose of 2 milligrams twice a day from the 25th day of the previous menstrual cycle. She then comes in on day 1 or day 2 of bleeding. The beauty of this is that estradiol valerate dose is so low that it does not inhibit menstruation, unlike a oral contraceptive pill, doesn't cause any over suppression of the hypothalamo pituitary ovarian axis, again unlike the oral contraceptive pill, but it prevents the follicle from growing. So it prevents the dominant follicle from cropping up. So she comes to you on day 1 or 2. You don't want to stimulate her for another week for some reason. You just continue the estradiol valerate, and then maybe you decide, okay, on day 8 I want to start the FSH, and you can stop the estradiol valerate on day 7. Or as some recent studies show, you can continue giving the estradiol valerate until the day of HCG without any adverse effects. So the beauty of this is you don't have over suppressive effects like the oral contraceptive pill. You have managed to postpone your stimulation and the egg retrieval by 3, 4, 5, 6, 7, maximum of 8 or 9 days. And the most important, you get a beautiful synchronization of the follicular pool. So please remember, the entire focus of pre-treatment is not just for scheduling and pushing around the dates of egg retrieval, but more so that you get a perfectly synchronous cohort. The biggest problem with the antagonist protocol as compared to the conventional agonist protocol was that you very often, in almost 30% of patients, get an asynchronous cohort. Many of you might have thought, okay, let's start on day 3 is fine, day 2 evening is fine. But sometimes this is too late because the dominant follicle has already been selected. And then when you check on day 7, you see one follicle is already, say, 15 or 16 mm. The others are still lagging behind at 11 or 12 mm. So this is not going to give you a uniform cohort. And then you end up with poor quality embryos or post-mature oocytes and so on. So please remember that pre-treatment is mandatory when you are doing an antagonist cycle. You cannot directly just start on day 2 or day 3 for all patients. Otherwise, you will end up with a lot of follicular asynchrony, which will not give you a good outcome at the end. So you can see this very interesting paper. And you can see here, when you use luteal phase estradiol, the cycle cancellation rate is less than half of against when you don't use estradiol. Number of oocytes marginally better, number of embryos also better when you give luteal estradiol. And in fact, this paper also showed that if you continue the estradiol through the stimulation until the day of HCG, the pregnancy rates were in fact higher at 27% as against 20% when you stop estradiol at the time of beginning FSH. Of course, there was no statistically significant difference, but there was a trend to better pregnancy rates and definitely no harm in continuing the estradiol. So of course, when you push it by 7 or 8 days, a lot of you will ask me, oh, but she will have an endometrium. There's no problem at all. She will develop a triple line endometrium on day 7, day 8, but no follicle, no dominant follicle will be recruited, which will ensure you get a synchronous cohort, and then you get a good endometrium as well because of this exogenous estradiol. So this is one of the very useful practical methods of doing a pre-treatment. The second easy way, if you're doing a batch IVF and you want to bring 20 patients together, all you need to do is give them norethistérone, and this was the classic Fisher protocol. You give them norethistérone 5 milligrams BID from day 20 if she has a regular 28-day cycle. You give it for a minimum of 7 days, maximum maybe 14, 15, even 20 days. You can stop anytime between the 7th and the 14th day. Usually we stop on a Sunday so that she bleeds on a Wednesday or Thursday, and you can start stimulation after the mandatory 5-day washout period on Friday so that you get a good uniform cohort. The simple thing this does, again, it suppresses the dominant follicle, so you do not have an asynchronous cohort, and also allows you to play around with the date by about 7 to 10 to 15 days. Coming to, of course, the oral contraceptive pills, which still most people continue to use and which I am really against, and I'll show you the reasons why. And of course, how people used to use it in the agonist protocol, they used to start it on day 1 or 2 of cycle, maintain it for 14 to 20 days. The agonist was then started 3 days before the last day of the OC pill. And then, of course, she continues with her down regulation program. Antagonist, it was started on cycles days 1 to 5, continued for 12, sometimes 20, sometimes 30, sometimes even 40 days, as per the dates of your scheduling or your batch IVF. And then stimulation is started days 2 to 5. I prefer 5 days after the last oral contraceptive pill, because that washout period is mandatory to prevent any adverse effects of the OC pill. And this, of course, gave you a homogeneous follicular cohort and also allowed you to schedule your cycles as per the convenience of your laboratory and the clinic. But it's not so easy. If you look at oral contraceptive pills in agonist protocols, which very few people are using anyway nowadays, there is just one RCT, which is way back from 1998, which showed that giving an OC pill in an agonist cycle doesn't really matter. Of course, significant reduction in cyst formations, because the flare-up effect of the agonist is countered with the oral contraceptive pill. They said that there was a shorter interval until the confirmation of downregulation, shorter duration of stimulation, decreased consumption of gonadotropins, and no significant difference in clinical pregnancy rates. So when you use an agonist protocol, maybe OC pill pretreatment doesn't really matter. But when you're talking of the antagonist cycles, which is what most of you must be using and most of the world is using, a very good meta-analysis here by Grisinger and Kolebianakis, and you can see ongoing pregnancy rates lower when you use oral contraceptive pills. Duration of stimulation is prolonged if you have used OC pills. Gonadotropin consumption greatly increased because of the oversuppression of the endogenous FSHLH, and fewer oocytes retrieved with OC pill pre-treatment. So it doesn't seem to be the ideal way of pre-treatment for most patients. So of course, various studies showed slower growth, lower estradiol levels, longer stimulation, higher consumption of gonadotropins. Recently, in 2017, Fakuhar also showed lower ongoing pregnancy rates and lower live birth rates with OC pill pretreatment in an antagonist protocol. And Kolebianakis in 2018 also showed higher miscarriage rate when you use OC pill pre-treatment. So please, please, please try to avoid the use of contraceptive pills. Of course, they're very convenient, very easy to advise, very easy to use, but doesn't seem to be the ideal way of pre-treatment for any category of patient. And I'll still elaborate on this more when we talk of the high responders or the PCOS patients. A very super way of really doing the best pre-treatment, very recently reported. Of course, initially Fanchin reported that you can just give one depot preparation of 3 milligrams of cetrorelix on the day 25 of the previous cycle for better follicular synchrony. But there is no need to administer so much of cetrorelix, and a lot of subsequent trials have shown all you need to do is give the antagonist on day 2, 3, and 4. And with this, you get higher number of oocytes, higher clinical pregnancy rates in the pre-treatment group, and a 5-fold reduction in the number of retrieval procedures on the weekends without significant differences in pregnancy outcomes. So what seems to be a very ideal way now is to go the antagonist on days 2, 3, and 4. That's all you need to do. This suppresses the dominant follicle, so you get a uniform follicular cohort and allows you to push the pickup by 2 or 3 days, so you can avoid the weekend if you have to travel for a conference or a meeting or a holiday or whatever it is. So you get both the goals are achieved with just 3 shots of the antagonist, and this works beautifully. We have been using this now for the last 1 year, and it really works like magic as far as getting a uniform cohort of follicles is concerned. What should be your first choice protocol? The agonist long protocol, the classic down regulation, or should we totally be shifting to the antagonist? Now, this is an ongoing war and a debate which goes on and on. Personally, I never gave up the agonist protocol. It's still my protocol of first choice for a lot of patients, simply for the reason that you not only get a very uniform cohort, uniform number and mature oocytes, but you also often get a higher number of top quality embryos because you suppress most of the aberrant or the abnormal endocrine milieu, which a lot of these patients might be having and which might be the reason for their infertility in the primary place. So of course, when it comes to high responders, any thin, lean PCOS patient, any PCO patient with a high AFC or an AMH, there's nothing much to think. You have to use only the antagonist protocol. It would be really playing with fire if you give her the long down regulation protocol, because you will invariably end up with hyperstimulation, and you don't have the flexibility of using the agonist trigger instead of the HCG trigger in a agonist down regulation cycle. So the agonist will be for about your 50 or 60% of patients who are normal responders or poor responders, and you cannot use it for the high responders. Of course, we all know the mechanisms of action. The long agonist, classically, of course, they have a short flare up and a short and a long, but the long is the gold standard and the favorite for all, where we begin the agonist from day 21, mid luteal phase of the previous cycle. Initially, you will have a flare up effect, which is why sometimes there is a cyst formation or a release of progesterone from the corpus luteum. Subsequently, there is down regulation of the receptors, and you have a complete abolition of endogenous FSH and LH release. So the LH surge is completely blocked, and you will not have a premature LH surge because of the agonist. The antagonist, on the other hand, has a direct effect and suppresses the release of endogenous FSH LH when it is administered from, say, day 6 or day 7, when the dominant follicle is 14 mm in mean diameter. So of course, all of you are familiar with these basics, but a few important points in fine tuning the protocols. And in the long agonist protocol, very important to make sure that the patient is really down regulated. Now, how do you assess down regulation? A simple rule of 5 which I have devised, and that is, she starts on day 21, she comes to you on day 3, day 4, or day 5 of menstruation. Usually that's about 15 days of the agonist. All you need to see and make sure is the endometrium is completely shed and less than 5 millimeters in thickness. There is no follicle or no cyst in either ovary which is more than 5 millimeters in diameter. FSH and LH both less than 5 MIU per ml. Estradiol less than 50, progesterone less than 0.5. So that's the rule of 5s, and you know that she is completely down regulated and now ready to begin stimulation. Why I am emphasizing this? Many a times, especially in batch IVF, you might find that 1 or 2 patients, despite down regulated, suddenly show a dominant follicle or a triple line endometrium because they have escaped the effect of the agonist. Either there was a problem with the batch or the cold chain, or was not administered properly, or whatever it is. And you must be careful of these patients, because you should not start them. They have to be cancelled from that batch, or they have to be re-administered a progesterone shot so that they again get a withdrawal bleed. You have to step up the agonist a bit and make sure that they're down regulated before you start stimulation. Otherwise, again, you will end up with an asynchronous cohort. What happens more commonly is over suppression. So you have to be very wary of this, because a little bit of LH is required for good follicular response even in the follicular phase. So if you use the agonist protocol, my personal choice is to use HMG and not use pure FSH for stimulation in these patients, especially if you've done a prolonged down regulation. So you must be aware of the need for LH in a lot of these patients. The most important point, you cannot give the agonist trigger. So if you have wrongly by mistake given a high responder the agonist protocol, you are in deep trouble. Either you have to cancel the cycle and face the wrath of the patient that why did you select this protocol, or you have to take a risk of OHSS, which you simply do not want in today's times. Of course, you can manipulate egg pickup dates as per your convenience. It's an advantage of this long agonist protocol. The drawbacks, of course, again, I repeat, higher risk of hyperstimulation. So case selection is very, very important. Because you have completely cut off endogenous FSH-LH, you need a greater dose of gonadotropin. So you need to start with, for example, 225, if you would otherwise have given her 150 with the short antagonist cycle. Prolonged treatment time and too many injections, so you might have some patient discomfort. Increased cycle cancellation rate for unexpected OHSS despite your best efforts to predict whether she is a normal or a high responder. And of course, you cannot use the agonist trigger or convert her to a freeze-all with complete safety like you can in the antagonist protocol. Antagonist, of course, very easy to use. Most of you familiar. Cycle day 2, ultrasound is what we do. If there is a complete shedding and the ovaries are quiet, you begin your FSH dose, call her in on day 6 or day 7 of cycle. If the leading follicle is 14 millimeters, don't go by a fixed protocol. Wait for the leading follicle to be 14 millimeters in mean diameter, and that is the day you begin with your the antagonist, and that is when you give 0.25 milligrams of cetrorelix or ganirelix and continue that with the FSH or HMG until the day the follicles are ready. So usually when you have 3 follicles in the range of 18 or 19 millimeters is the day we withhold the FSH, just administer the antagonist in the morning, and you can give the trigger in the evening or the night and then do the egg retrieval at 36 hours. So you're familiar with this, but again, practical points. Pre-treatment is very, very important. When you're using an antagonist cycle, please do pre-treatment either with estrogen or with norethisterone or with the antagonist on day 2, 3, and 4, so that you do not get follicular dominance, and avoid OC pills in all categories, especially in high responders. Now, a lot of you would wonder why I'm emphasizing high responders, and I'll show you in a little while as to why that is not ideal. Antagonist should be given at 14 millimeters of mean diameter. That is a flexible protocol and not a fixed day that for everyone you start on day 6 or day 7, because everyone may not have a follicle of 14 millimeter on a fixed day. When you start the antagonist, there is no need to increase the FSH dose. This was initially thought that because of the suppressive effect, we might have to pump in more FSH. So it was common practice to increase the dose by 75 or 150. You do not need to do that. A lot of studies have shown that that is futile and is of no benefit to the patient. You could add LH or switch to HMG if she is a hypo responder, means the follicles are growing very slowly, stagnant for 7 day, 7 day, 9 day, 10, it remains at 12 mm, 11 mm, 13 mm, then maybe you could add LH or switch from pure FSH to HMG in these patients to enhance the growth of the follicles. Time between 2 antagonist injections should not exceed 30 hours, very important. Coasting is not recommended. Now here is the important point, that if the egg retrieval is falling on a Sunday, the follicles are ready on a Friday, do not push it to Saturday, otherwise you are going to cause a lot of problems with the egg maturity and the number of top quality embryos that you get. So that is why it's difficult to use the antagonist in batch IVF, because you cannot coast or play around with the egg pickup date as you could with the agonist. Do we have an alternative to injections? And recent reports, very promising and encouraging, although personally I have not yet started using it, is the use of progestins such as oral medroxyprogesterone acetate. It just has to be given daily in a dose of 10 milligrams when you start FSH or HMG from day 2, so that you don't add any more injections to the FSH. Effectively blocks the premature LH surge. So you just give 10 milligram MPA orally along with the FSH. No need to use agonist or antagonist or what we've been doing for the last 25 years. But because of the adverse effects of this progesterone on the endometrium, you have to do a freeze-all, and you cannot do a fresh embryo transfer when you use progestins or MPA for preventing a premature LH surge. So how did this come about? Kuang was the first who reported the first RCT with progestin primed ovarian stimulation. And they showed that although the duration of stimulation is significantly longer, you consume more gonadotropins because of the progesteronic negative feedback mechanism, but the number of mature oocytes and the main reproductive outcomes were the same between the two groups. But you need to be cautious, because there has been 1 or 2 reports where they found that in egg donors, when MPA was used, the pregnancy rates in the recipients were probably not the same as you got with conventional agonists and antagonists. However, we need further studies. And very recently at ESHRE, there is a study which has compared the same outcomes and found that the pregnancy rates are the same even in an egg donor program. So we need some more RCTs before we routinely start using MPA instead of the agonist or antagonist to prevent the premature LH surge. Do you need 10 milligrams or can you use something lower? And we have this one paper from 2019 which shows that even 4 milligram of MPA is the same, it gives you the same outcomes as 10 milligrams as far as number of oocyte retrieved, pregnancy outcomes, and preventing the LH surge is concerned. So 4 milligrams of MPA also should suffice to prevent a premature LH surge. But again, I repeat, you cannot do a fresh embryo transfer. And the absolute final end result with terms to live birth rates is still needs more conclusive RCTs to be conducted. After pre-treatment, the most important point as a clinician for you in your IVF center is to select the correct initial dose. It is common practice. A lot of people get scared of OHSS. So they start with 100. Then on day 7, day 8, they see, oh, she's not responding adequately. She has just 4 follicles. Let me now make it 225 or 300 because now she will not have OHSS. This is bad practice. This is not going to give you a good final outcome. So it's very important to select the correct initial dose and be prepared that you might have to use an agonist trigger, you might have to do a freeze-all, and you won't cancel the cycle come what may, but you will get your targeted 20, 25 or 30 oocytes. Of course, what does the dose decide? A decision depend on the age of the patient, the BMI, the AMH, the AFC, previous response if she's had any IVF cycles in the past, and whether there is associated endometriosis or she's a potential high responder such as a PCOS. So you have to take into consideration all these factors when you decide the correct starting dose. For normal responders, do not start with 100 or 150. You can see here, huge studies have shown significantly higher number of oocytes with 200 as compared to 100 for a normal responder patient, also higher with 200 or 225 compared to 150. So 100 or 150 should not be used. Some of you would say, then why get into all these calculations? Why not just give 300? But 300 doesn't really have any significant benefit and would add on to the cost of the cycle. So the ideal dose for a potential normal responder should be 200 or 225 IU of FSH or HMG. So this is very important take home point. And again, you can see cycle cancellation for either a very poor or a very high response again is in favor of using 200 and not using 100 in normal responders. So please be very sure that you give her the correct starting dose. More than 225, classic study by Blockhill 2020. And you can see here that more than 225 is probably not required for any patient of any category. It doesn't help a poor responder, as I'll show you subsequently, that you give a 300 or 450 or 600. And it doesn't help a high responder also because you will just get, you don't want more than 25 or 30 oocytes. So getting 50, 60 or 70 oocytes doesn't really make sense and would increase the risk of ovarian torsion. So either way, for all categories across all types of responders, the best response, the highest dose should be 225. If at all she's a very high BMI patient, the max you should go to is 300 for any category. I'm sure all of you agree that almost 20 to 30% of your patients are polycystic ovaries or high responders with high AMH and high antral follicle counts. And we know, as a lot of studies have shown, that they do constitute almost 30% of all IVF patients. And they are a difficult category to treat because they not only have infertility, but also have a propensity to higher early pregnancy losses. And I'm going to emphasize this again and again because now it's not just about getting eggs and embryos, but getting a take-home baby or a live birth. What about oocyte quality? In high responders, we know we get quantity-wise, there is no problem. You will get your 20, 30 oocytes. But should we be wary of oocyte quality? And there are studies which have shown that in PCOS patients, especially those with obesity or insulin resistance, they do have a lot of abnormalities with mitochondrial morphology. So don't go just by the numbers. You have to counsel the patients accordingly that we will get a lot of eggs, but they may not be of the best quality. And it is also known that high fat diet and obesity will cause reduced mitochondrial membrane potential, both at the GV and the metaphase 2 stages, giving us poor oocyte and embryo quality in these women. So it's important to remember this. And very important, the ASRM guidelines. Of course, this is a little bit of diversion from our main topic, that letrozole should be considered as first-line treatment for the PCOS patients. Clomiphene can be used with metformin for women who are CC resistant. The risk of multiple pregnancies increased with clomiphene, so monitoring is critical. Gonadotropins could be used as a second-line treatment if aromatase inhibitors or clomiphene have failed. If it's a good IVF clinic with a lot of experience with the use of gonadotropins can also LOD can be used if laparoscopy is required for some other reason and not just to do the drilling. You must always remember that drilling could cause periadnexal cell adhesions and impair her fertility further, and also cause maybe a sudden loss of the ovarian reserve and a drop in AMH levels. And finally, of course, you have to counsel the patient whenever you're using gonadotropins that there would be an increased cost. You would need a lot of monitoring. You should prefer low dose protocols, the chronic low dose step up protocol to optimize monofollicular development. And she should also understand the risks and implications of multiple pregnancy. So which patients, which high responders need IVF? Of course, when they have other factors such as tubal endometriosis or male factor, despite 6 ovulatory cycles, if she fails to conceive, if she fails to conceive with weight reduction, letrozole, LOD, gonadotropins, and IUI, sometimes if she has an excessive response, means you started her as an IUI patient, and then because of the excessive response, you need to convert her from IUI to IVF. And of course, finally, if you do not want multiple pregnancies at any cost in a given patient, the best treatment is to do IVF with a freeze-all and an elective single embryo transfer to make sure that you don't get a high order multiple pregnancy. Since I spoke about converting an IUI to an IVF, some of you might think, oh, last minute conversions don't work, they wouldn't be successful. It's quite the contrary. So if you don't have a primary IVF center and are doing only IUIs, always tie up with a local neighborhood friendly IVF center. And remember that this is one of the most successful conversions you can do. And this paper here shows where they had started off as IUI and then they saw instead of 2 or 3, the patient had say 10 or 15 follicles. You have already spent the money on the gonadotropins. You have given her the lowest possible dose. You know in the future also she will respond the same way. Best is to convert her to an IVF and you are not compromising her results. You can see here rescue IVF group clinical pregnancy rate as high as 45%. And in fact, the normal IVF group, the planned IVF group, clinical pregnancy rate was 33%. Of course, this difference is not because it was a last minute conversion, but because these were easier, simpler patients, probably younger, because they were recruited for IUI in the first place. So obviously they give you more oocytes, better quality embryos, and therefore a higher clinical pregnancy rate. So all you need to do, give her the antagonist, send her to the IVF clinic, let them do a agonist trigger, freeze all, transfer, and 5 out of 10 are probably going to walk out with a baby in the first frozen embryo transfer. So you are not compromising her in any way, and it works beautifully when you do a rescue IVF. So what are the challenges which we face in PCOS? And each of these points is very, very important because all of you know that whatever dose you decide, either she will not respond or the ovaries will just explode and you will have an exaggerated follicular response with hyperstimulation. It's very difficult to titrate doses in these patients. Before the days of vitrification and the agonist trigger, a lot of them ended up with either OHSS or cycle cancellations. The more the eggs and the follicles, the higher the tendency to premature progesterone rise on the day of HCG. Poor oocyte quality, as I showed you earlier, mitochondrial defects, fewer top quality embryos, and increased risk of spontaneous early pregnancy loss. So each of these things have to be considered when we are talking of stimulation in a high responder. One slide to say it all, what works best for these patients is the 3 musketeer approach. You have to select the antagonist protocol. You cannot use the agonist protocol. 99 out of 100 might require the agonist trigger. So if they have more than 15 follicles, you cannot give an HCG trigger. It's not safe. And because you use the agonist trigger, you will have deficient corpora lutea, a very deficient luteal phase. Fresh transfer will not give you a good pregnancy rate. You will have to do a freeze-all and a subsequent transfer in the next month. So you must maximize the number of eggs so that she doesn't have to go through the procedure again. And you keep it absolutely OHSS free by using the agonist trigger and the freeze-all policy. Now, a lot of you might feel that, oh, this agonist trigger doesn't give good eggs. You don't get the top quality embryos when you compare to an HCG trigger. Why not add back HCG? My vitrification results are not that great, so freeze-all may not be the right way to go. So there are a lot of things which need to be considered here. Now remember that when you give an agonist trigger, which is usually 0.2 or 0.3 milligrams of triptorelin, the half-life is very short compared to HCG. So you can see the half-life is very short when you compare it to HCG, which is almost 7 days. Of course, this is the reason the corpora lutea resolve within 24 hours and you don't get any hyperstimulation, even if the patient has given 70, 80 or 100 oocytes as compared to HCG. But the problem is that you cannot use it in agonist cycles because the agonist trigger works on the principle of releasing endogenous FSH and LH. In an agonist cycle, you have already downregulated her. She doesn't have any endogenous FSH LH left which can be released, and therefore it cannot work. The biggest problem, of course, is the luteal phase deficiency. So these are some basic points about using the agonist trigger. What dose should you give? 0.2, 0.3, 0.4. There was a dose finding RCT, showed the same outcomes. The number of good embryos, everything was the same. And you can see here, even here, the fertilization rates, recovery rates, number of metaphase 2s, all comparable when you use 0.1, 0.2, or 0.3 of triptorelin. So now, personally, I prefer to use 0.2 because it covers all the problems for BMI and so on and so forth. And it seems to work well for across all classes of patients. Now the most important slide, why I told you not to give OC pill pretreatment when you are contemplating an agonist trigger. And that is why in high responders, in PCOs, in egg donors who are likely to give you more than 15 oocytes, do not use OC pill pretreatment. And why? Many times I get phone calls that my patient, I give her, she had a high responder, she had 30 follicles, I got 20 oocytes, but I got only 5 metaphase 2s, I got only 1 embryo. What could be the reason? The reason is nothing else but the OC pill pretreatment. And you can see here, the lower the LH at the start of stimulation. So if you have given her more than 12 days of OC pill pretreatment, she will have over suppression of LH at the start of stimulation. And the more the suppression of LH, the higher is the percentage of cycles with a suboptimal response. So you can see if the starting LH was less than 0.1, almost 50% of the cycles will not give you a good outcome when you then give her the agonist trigger, because the agonist trigger needs good amount of endogenous FSH and LH to be released to give you your final second maturation division and your conversion to metaphase 2 oocytes. So this is a very important problem, very important clinical point, very often neglected and forgotten. Nobody thinks of the pre-treatment when something goes wrong, but most often, as Blockhill beautifully showed in this study here, that it is the OC pill pre-treatment. So if at all you have to give OC pills, it should be just for less than 10 to 12 days. Anything more than that is not going to give you an ideal outcome if you use an agonist trigger instead of HCG. The second important problem in these high responders is premature progesterone rise. And this you can see, the greater the number of oocytes retrieved, the higher is the percentage or incidence of progesterone elevation. So if you have more than 18 oocytes, almost 1 in 6 or 1 in 5 patients will have a premature progesterone rise. And we know that the more the progesterone rises on the day of HCG or 2 or 3 days before, the more the advancement of the endometrium, because the secretory changes already begin to happen. And if that endometrial advancement is more than 3 days, by the time you do the embryo transfer, your pregnancy rates are almost 0% with a fresh transfer. So it's very important that you are wary and aware of the PPR problem. Some of you might argue that why not add back HCG when I give the agonist trigger and still do a fresh transfer and get the same pregnancy rate? Yes, you could do that. There are studies which show that you give agonist trigger and then an add back 1500 IU HCG on the day of egg retrieval and then do a fresh transfer. Yes, you get back your 50% clinical pregnancy rate, but you still have 1 in 6 patients having ovarian hyperstimulation. And this is often the dangerous variety because it is the pregnancy induced late OHSS, which goes on for 15-20 days. And you are familiar with the ascites and the pleural tappings and the protein drips and all the problems that you could encounter. So this is best avoided. If you have a good vitrification program, you should completely avoid add back HCG and fresh transfer in high responder patients. Then you would argue, but does FET really help in these patients? There are enough studies now to show that if you do a freeze-all, whenever you have a premature progesterone rise, you do a freeze-all and a transfer in the next cycle, you can see here the blue bars, you have much higher live birth rates as against if you were to do a fresh transfer in a patient with high progesterone. So of course, it's a debatable topic and I'll be covering it in great details in my module next Friday when I talk about the frozen embryo transfer and the freeze-all strategy. But it's important to talk about it today because it completes the section on stimulation of high responders. So when you do a freeze-all, you definitely restore your pregnancy rates to the same good 40 to 50% with these high responder patients. And this was confirmed by Raka and Blockil. You can see here, progesterone more than 1.5 on the day of HCG, progesterone less than 1.5. And finally, the cumulative live birth rates when you do frozen transfer in this high progesterone group compared to fresh transfer in the normal progesterone group, your pregnancy rates are the same. So this is a very important point here, that progesterone, when it is elevated on the day of HCG, affects endometrial receptivity and does not affect oocyte quality and embryo quality. If it, of course, doesn't go beyond 2.5, in which case it can even affect the oocyte and embryo quality. Nothing better than your own experience always. And why I talk so strongly about the 3 musketeer approach, about 5 years ago, we first switched to doing this for all our PCOS patients. So this was our short study of about 127 patients, short antagonist cycle with a fixed dose of REC FSH 150, 0.2 milligrams of triptorelin as the trigger to all of them. Embryos were frozen on on day 2 at the 4-cell stage and subsequently transferred in the next month at the 8-cell stage in a GnRH agonist downregulated and estrogen progesterone primed cycle. And as expected, pregnancy rates, first frozen embryo transfer 56.6% positive beta HCG, reduced number of early pregnancy losses, and giving you a good take-home baby rate of close to 50% with this very difficult category of patients, which is otherwise to treat. A lot of us also do rapid knee-jerk reaction dose reductions on day 7. So you started with 225 and then you say, oh my God, she's got 25 follicles. Let me reduce to 150. Now this is just going to help you psychologically, but doesn't help the patient in any way. You can see here, whenever you reduce a dose, it takes 3 days. So from day 7, if you reduce the dose from 300 to 150, it takes 3 days for that dose to then go below the threshold which is required for new recruitment, which means, simply put, that new recruitment continues for 3 more days. So you have reduced the dose, but you will still, if you had 15 follicles here, you might have 25 follicles by day 10 when you, in fact, that reduced dose works. So this doesn't really help. And in fact, it just might reduce the estradiol levels, make you psychologically secure. But this sudden drop in estradiol, in fact, is detrimental to oocyte quality and embryo quality. So it's best not to panic. You must always be prepared that you might have to give the agonist trigger and do a freeze-all for these patients. Don't panic even if you see 70, 80, 100 follicles. Nothing happens. It is 100% safe when you give an agonist trigger and withhold HCG in these patients. So you can see here, even if you completely stop administering the FSH or HMG, you will still have follicular volumes increasing for another 5 or 6 days before they start regressing. And even if you reduce or maintain the dose, the follicular volume will keep on increasing and there will be no reduction in the severity of the stimulation or the hyperstimulation. So please remember that dose reductions do not work in these patients. Suppose you have inadvertently given a high responder the long agonist protocol and you find 15 or 20 follicles. What do you do? If you ask me, the safest way out, especially if there are more than 25 follicles, is to cancel the cycle. You don't want OHSS. If you are a good clinician and a good clinic, you should be free of OHSS. Every high responder has to be counseled before being given an agonist cycle that we might have to cancel the cycle. Lowering the dose, I told you, doesn't work. Coasting doesn't work. Freezing, yes, you could. You do a freeze-all because we know pregnancy makes hyperstimulation even more severe. So if you just freeze, don't do a transfer, maybe then give her your cabergoline, or maybe you continue the agonist, the ovaries would settle down, but she would need some intervention and would be in pain for a week to 10 days. And that's the way you would have to take these cases forward. So best is, of course, prevention, means don't use the agonist protocol for high responder patients. If you do, then your only options are either cancellation or just freeze all and take a small risk of mild OHSS for a week, which can be controlled with cabergoline and the agonist. What about adjuvants? We see so many adjuvants being given to the high responders. Please remember, insulin sensitizers will only help patients with proven glucose intolerance or insulin resistance, obese patients, CC resistant women. For reducing OHSS in agonist protocols, which you're not supposed to be using in the first place, but if you have, then maybe metformin might reduce the severity of OHSS. Alone, they are less effective than clomiphene or letrozole. And there were initial reports that said that it might help in reducing early pregnancy losses, but that only holds true for these two categories of patients where metformin would benefit you. Now, a lot of the papers which said metformin will improve IVF outcomes, will improve live birth rates, were all before 2000. That's almost 20 years ago. If you see the recent publications, this Cochrane meta-analysis 2014, metformin before, during, or after stimulation does not improve live birth rates. Lower incidence of OHSS in long agonist cycles, but not in short antagonist cycles. 2016 again reduced live birth rate with metformin versus placebo. No difference in hyperstimulation or number of oocytes. And in 2018 again, Abdul Magid showed no significant difference in live birth rate, even in agonist protocols with addition of metformin. And in fact, they had less oocytes in the metformin group, which of course, as the earlier study showed, lower incidence of hyperstimulation means fewer number of oocytes, but no benefit in terms of improving live birth rates. The most interesting and exciting advance that we've had in this year for high responders is a complete turnaround in our thinking of what PCO patients need. We have been tuned. We started 28 years ago. At that time, we had only HMG available. When I started my practice, we were using only a drug called Pergonal for everyone, which had FSH and LH in equal proportions, was the classic urinary HMG. We then had studies which said PCO, they already have elevated LH, their ratios are disturbed, they should not be given LH. So we went into pure FSH, then highly purified FSH, then recombinant FSH. Now, do we have any evidence that maybe it's time to go back to HMG for PCO patients and high responders as well? And this is probably one of the greatest breakthroughs that we have in this year. And let's give a little bit background to this, that does the choice of gonadotropin, means whether you use REC FSH or HMG, affect success rates in high responders? So we know that with REC FSH, you get more oocytes. So obviously the risk of OHSS is higher, especially in high responders. We also know that the more the number of oocytes, the higher the incidence of premature progesterone rise. So again, that would be higher with REC FSH cycles. What we did not know is, does the choice of gonadotropins affect embryo competence, cumulative live birth rates, FET pregnancy outcomes, and early pregnancy losses, which is a big problem in the PCOS group. And of course, first, let's take a little background of the tendency to PPR. And this was one of the first studies in 2007 comparing HP-HMG with REC-FSH. Now, mind you, HP-HMG is not routine HMG. It is HMG which doesn't contain native LH, but HCG-driven LH activity. So it's very important to remember that everything I'm going to speak about now is about HP-HMG with HCG-driven LH activity and not conventional HMG with native FSH and native LH. And you can see here, this study had shown that the progesterone levels significantly lower with HP-HMG as compared to REC-FSH in high responders. So this was the first clue we had way back in 2007. 2016, Sharara showed at ASRM again that when you use a combination of urinary FSH with HP-HMG as against only HP-HMG for a high responder patients, you have a significantly lower incidence of premature progesterone rise. So again, there was evidence that HP-HMG gives you a lower incidence of premature progesterone rise. What about embryo quality? When we talk of mitochondrial defects and embryo quality in PCOS patients, Zebe in 2007 did a classic study showing about comparing HP-HMG and REC-FSH as to top quality embryos available for transfer. And you could see here, HP-HMG gave significantly more top quality embryos compared to REC-FSH, therefore gave you significantly higher implantation rates and also live birth rates. So you can see here, in patients with only top quality embryos transferred, almost 50% in the menopure group achieved live births versus around 30% with the REC-FSH group. So these were the first clues we had almost 12 or 13 years ago, that maybe this HCG-driven LH activity has some secret which gives you a better outcome. So then they thought that what about addition of HCG to REC-FSH? So instead of using HP-HMG, even when you add HCG, the more HCG that you add to REC-FSH, the higher the HCG added, again, you have a higher number of top quality embryos. So addition of HCG to REC-FSH also gave the same performance and gave you more top quality embryos. The reason is that HCG tends to accumulate. LH has a very short half-life. Within a few hours, it is washed out. HCG accumulates in the system. So if you start HCG from day 2, as when you give HPHMG, or if you add HCG to REC FSH, there will be an accumulation of HCG. And the higher the HCG level on day 6, you can see here, the greater the HCG level on day 6, the greater is the proportion of top quality embryos that you get. And this was shown by Zibe in 2007. And this translates into live birth rates as well. You can see here, LH does not accumulate. So the live birth rates do not change, however high LH is on day 6. But HCG, when you compare, the higher the HCG on day 6, you can see much higher is the live birth rate. So you have a tremendous increase in live birth rates when you are using HCG driven LH activity as against normal, say, rec LH or HMG, which contains native LH. So this is a very important slide and a very important take home point, and purely because of the cumulative effect of HCG, which keeps increasing in proportion the more the number of days that you administer it. What about hyperstimulation? We have this mental perception that antagonist protocol gives us lower hyperstimulation as compared to the agonist protocol in high responders. But you can see here this study in 2014, which showed very clearly that till now we thought that the high ovarian response and severe OHSS is higher in agonist protocols, but this was purely because in antagonist, you can give the agonist trigger and not give severe OHSS. But if you see high response, if you just compare the number of oocytes in agonist and antagonist, it is the same. So what makes a difference is again the gonadotropin used. You can see here the green bars are the REC FSH in the agonist protocol or the antagonist protocol. Percentage of high responders are the same. So it is not less with the antagonist as we keep thinking. But with HPHMG, you have a significantly lower incidence of a high response. And also they further compared live birth rates, and you can see they were much higher with HPHMG as compared to REC FSH in all the groups. So again, this showed that the choice of gonadotropin is what needs to be given a lot of consideration rather than just whether to use agonist or antagonist. Of course, we know we have to use the antagonist, but we also need to now give a lot of attention to what gonadotropin should be used. And you can see here the risk of developing a high response when you are expecting a high response may be reduced by 1/3 with the elective use of HPHMG, even in an antagonist protocol. And why is this? Because maybe the FSH isoform profiles in HPHMG and REC FSH are different, which affects the in vivo biopotency in human subjects. And you can see here LH activity in HPHMG early on in the follicular phase induces an initial higher level of androgens. This causes upregulation of the FSH receptors, decrease in granulosa cell proliferation, and therefore influences the number of follicles recruited. And therefore you have fewer follicles recruited with HPHMG as compared to REC FSH in a high responder patient. And now the first thought that all of you would have is, then how does that help? If you get fewer oocytes, what's the point? And that's exactly what I'm coming to in a while. Also, as expected, premature progesterone rise in this study was lower after HPHMG as compared to REC FSH. And now we have this huge megaset trial. That is, for the first time, we have a comparison of HPHMG, that's Menopur, with REC FSH in antagonist cycles with a single embryo transfer in high responders. So a lot of you have heard of the original megaset trial, which was for all categories of responders. This trial is specifically for the high responder patients, conducted over 31 centers in the US, recently published. The first important point you can see here, estradiol levels increase twice as much with REC FSH on day 6 as compared to HPHMG. This is expected because you have more oocytes and therefore you have more hyperstimulation. When you look at fresh cycle pregnancy rates and outcomes, HPHMG gave a higher pregnancy rate, live birth rate per transfer higher with HPHMG, early pregnancy loss significantly lower with HPHMG when compared to REC FSH. So this was an interesting observation that your outcomes are better despite HCG driven LH activity being administered to PCO patients and high responder patients who till now were thought that we do not need to give them any LH. Beautiful series of slides here. You can see you get 7 fewer oocytes with HPHMG as compared to REC FSH. So you would think that's not good. In the beginning of the lecture, I said more the oocytes, better it is for cumulative live birth rates. This translates to 5 fewer metaphase 2s. So you get 7 fewer oocytes. When you denude them and assess the maturity, you have 5 fewer metaphase 2s. You have 4 fewer zygotes. You have 3 fewer blastocysts. So till now, we keep thinking that it's not doing as well as rec FSH, but when you compare top quality blastocysts, there is no difference. So it's the same when you compare the number of top quality blastocysts that you get with HPHMG as compared to rec FSH. So the whole advantage of getting 7 more oocytes is negated when we see the progress of the oocyte to a top quality blastocyst. So when you then consider frozen embryo transfer outcomes in these patients, again, HPHMG give higher pregnancy rates, cumulative early pregnancy loss much lower with HPHMG, cumulative early pregnancy loss fresh and frozen both put together, again much lower with HPHMG. Cumulative live birth rates means when we talk of all the pregnancies for the fresh and all the frozen transfers put together, you will see they look more or less the same as expected. You have almost a 50% cumulative live birth rate in both the drugs, but the cumulative live birth rate with HPHMG in 6 months after the initial egg retrieval is achieved with fewer transfers. So 43 less embryo transfer procedures had to be done, and 65 less fewer embryos were transferred to get the same cumulative live birth rate. So this is very important observation here. And you can see here also hyperstimulation significantly lower with HPHMG because you have 7 fewer oocytes. So obviously you get lesser hyperstimulation. And the trial concluded that HPHMG was non-inferior to rec FSH with respect to ongoing pregnancy rates. Comparable cumulative live birth rates associated with fewer transfer procedures and lower number of embryos. Higher ovarian response with rec FSH getting more oocytes did not confer a clinical benefit and in fact associated with higher incidence of OHSS. Reduced early pregnancy loss rates were reported with HPHMG in both fresh and frozen cycles. So this is a very important point here, very important take-home message. What about the final outcome? Of course, we have papers from way back in 2004. When you compare PCOS with tubal factor, that you have the similar pregnancy rates. So it's not that they have lower pregnancy rates with IVF, but of course, they have a higher incidence of early pregnancy loss. They have a 3 times higher risk of gestational diabetes, almost a 4 times higher risk of pregnancy-induced hypertension, preterm deliveries, increased perinatal mortalities, and so on. And finally, of course, to conclude the high responder part, we have the ESHRE guidelines that OC pill not recommended, especially more than 12 days, 12 to 28 days. Antagonist protocol is definitely recommended for safety. Addition of clomiphene or letrozole not recommended to reduce hyperstimulation. Rec FSH and HMG are equally recommended. Adjustment of the doses mid-stimulation is not recommended. Routine use of adjuvants, again, not recommended. Addition of estradiol measurements is not required. Agonist trigger is recommended in women at risk of hyperstimulation. If you do that, you need the freeze-all strategy to eliminate the risk of late onset hyperstimulation. Cabergoline or albumin, etc., are not required or recommended when you give an agonist trigger. So please sleep tight and safely. Once you have given the agonist trigger, you don't need to give her cabergoline, albumin, or any other thing because nothing happens. Ovaries just settle down to normal size within 24 hours. Moving on next to the most difficult category, and that is the poor responder, because I'm sure all of you agree that almost 40-50% of your patients do not respond the way you want them to. And this slide is very important because if you understand this slide, you understand the management equally well. So presence, there are 3 categories of poor responders. One, who starts with a decreased ovarian reserve. So she doesn't have enough number of FSH sensitive follicles. So these are your classic patients with the low AFC or low AMH. The second category, the patient had enough follicles, but you didn't give her the right dose. So inadequate dosing for her BMI is the second category, that's Poseidon 1 and 2. And finally, you have a category where she has enough follicles, you gave the right dose, but she is a carrier of polymorphisms. So the ovaries were insensitive to whatever preparation of FSH or HMG you gave her. So these are the 3 categories you need to understand so that the management is simplified. And I'm sure you already heard this by the earlier speaker. So you have groups 1, 2, 3, and 4. Of course, groups 1 and 2 are the unexpected groups. These are young and old patients who started with a normal ovarian reserve but gave you a suboptimal response. You have 1A if you get less than 4 oocytes, 1B if you get less than 10 oocytes. And of course, you have group 3 and 4, which are young and old patients who started with a decreased ovarian reserve and they were expected not to do well with stimulation. So let's do 1 and 2 first. And we know the commonest causes, besides inadequate dosing or the presence of polymorphisms, the most important practical point, which I am again repeating, is follicular asynchrony. Very, very often we start, especially in poor responders, you begin your FSH on late evening of day 2 or early morning of day 3, sometimes even day 4. The dominant follicle has already been selected and you will not get a uniform cohort. The best treatment options, antagonist protocol with good pre-treatment. As I told you, antagonist on day 2, 3, 4, then begin FSH from day 5, then again the antagonist when the follicle is 14 millimeters, and so on. My personal favorite is, of course, the agonist protocol with the use of HMG and not pure FSH. You could increase the dose in the next cycle if it was a case of inadequate dosing, or you could add LH and use HMG instead of using FSH. So these are the 4 treatment options you have for groups 1 and 2 of the Poseidon classification. Already discussed earlier, either you use luteal estradiol or norethisterone or the antagonist. OC pill, if at all, not more than 10 to 12 days. So this is a very important point. You must give pre-treatment if you are using the antagonist protocol. You can see here the study by Blockhill in 2011, antagonist on days 2, 3, and 4. And you can see here number of oocytes retrieved in the control group 9.9, number of oocytes in the antagonist pre-treatment group up to 13.6. So you get significantly higher number of oocytes when you do antagonist pre-treatment on days 2, 3, and 4. Some patients have high progesterone before the start of treatment. So on day 2, a lot of us give attention to high progesterone on the day of HCG, but remember that high progesterone on day 2 is equally important. And you can see here, if progesterone on day 2 is more than 1.5 for a persistent corpus luteum cyst or whatever reason it could be, your pregnancy rates are very low as compared to the normal progesterone group. This has been known for 16 years, but somehow nobody pays attention to high progesterone on day 2. So we had numerous reports of administering the antagonist for these patients, but finally we have this study from Blockhill in 2011. Antagonist is given on days 2, 3, 4. You begin stimulation from day 5, then antagonist when the follicle becomes 14 millimeters, and then go on to your egg retrieval. And you can see the minute you give 3 days of antagonist, the progesterone levels normalize from 3.3 to 0.8. And with that, your pregnancy rates also come back to normal, as same as the normal progesterone group. So this is a very interesting area to fine tune your practice and make sure that you don't miss these patients with high progesterone on day 2 of cycle. What about, again, increasing doses on day 7 for poor responders? We spoke about decreasing doses for high responders. Again, it doesn't work. This is day 7, your decision point as to what you should be doing. Maintaining the dose. If you increase the dose on that day, on day 7, again, it is going to take 3 days for the new dose to take effect. Now see here, the follicular diameter from 2 mm has gone to 12 mm on day 7. You are then increasing the dose because you don't have adequate follicles. Day 10, you may again get a follicle of 2 mm, but by then this follicle would already be 15 or 16 mm and she would be ready for the trigger by day 11. These follicles are not going to be ready, so it's no point increasing the dose at this stage to get more follicles. The only point of increasing the dose is if you don't have a response. On day 7, you see nothing, then you could probably increase the dose and reassess her after 4 or 5 days to see if the increased dose gave you any more follicles. So please remember that any new recruitment on day 10, because 3 days go in achieving the threshold, will not achieve maturity until day 18, but the initial cohort is ready by day 10, day 11. So this is not going to work in any way for you. What about agonist versus antagonist, again for poor responders? And you have this large study here. Of course, this was for normal patients in fresh embryo transfers from 2019. And it clearly showed again that the agonist does much better in terms of number of oocytes, embryos, clinical pregnancy rates, and live birth rates. So there is a story for continuing the use of the agonist and not giving it up. And this was our own data and classic study because the patient herself was her own control. So what we did is, these were all poor responders in the age group of 32 to 36 with low AMH. 36 patients. First cycle, we did the conventional antagonist with a combination of REC, FSH, HP, HMG. Second cycle, we did agonist cycle with HP, HMG 300 IU. Clearly, higher number of oocytes with the agonist. Most importantly, you have almost a doubling in the number of top quality embryos that you get with this approach. So till now, we were taught that poor responders are already suppressed. If you give the agonist long protocol, you are suppressing her more, you will not get more oocytes. In fact, it's the contrary. When you give them HP, HMG with agonist, you get more oocytes, you get more top quality embryos, and therefore you get higher pregnancy rates in this category. What about increasing FSH doses? You don't need to go ballistic and double the doses. If the first cycle gave you fewer oocytes, Poseidon 1 and 2, you think the dose was not adequate, just increase by 75 in the next cycle. So you can see when you go from 200 to 275, you have a significant increase in the number of oocytes. So you don't really have to double the doses. You just need to add 75 IU. A lot of you would say, why is he talking of 4 eggs and 5 eggs and 7 eggs? Does 1 egg really matter? Yes, it does. We are discussing poor responders. They are going to give you only 3, 4, or 5 oocytes. And this classic study from 2017, you can see how with each additional egg that you get, there is an increase in the live birth rate per cycle. So you can see from 1 to 5 oocytes, how number of oocytes is very, very important for poor responders. Group 3 and 4, of course, remember these patients don't have follicles. So giving any amount of dose of gonadotropins will not compensate for that fact. They are low AMH, low AFC, poor responder patients. Again, the treatment options are similar: agonist better or antagonist better, HMG better or FSH better. What about embryo accumulation? What about the role of PGT? And what about dual stimulation? So again, you can see this study from 2018 for Poseidon group 3, young patients with a poor reserve. Agonist cycle gives you a much higher live birth rate, almost double of what you get with the antagonist. Maximal gonadotropin dose study from 2010 comparing 300 versus 450 versus 600. Clearly no difference in live birth rates. And the authors go further to say that for groups 3 and 4, your standard dose should be just 150 because she just has 2 or 3 follicles. To support the growth of those 2 or 3 follicles, 150 is more than enough. You don't need to give her 300 or 450 or 600. Of course, for a high BMI, you could go up to 225 max. More than that is not required. Something which personally I'm very excited about for poor responders is the dual stimulation. We have been doing a lot of these patients for the past 6 months to 1 year almost. In fact, we started last November, about 4 or 5 months before the lockdown. And this exploits the fact that a woman doesn't have just one phase of follicular recruitment, which we thought until now that follicles are only in the follicular phase. We now know that 1 in 3 women have 3 waves of follicular recruitment, and 2 in 3 women have 2 waves of follicular recruitment. That means you can recruit follicles again and again during the same menstrual cycle. So this was Ubaldi's original paper, which first stimulated us that there is something in this story. And it was very easy to do. What they did, REC FSH and REC LH from day 2, then add the antagonist when the follicle is 14 mm. Agonist trigger, even if you have only 5 follicles, just give the agonist trigger, don't give HCG. Do your egg retrieval at 36 hours, stop for 3 or 4 days, restart REC FSH, REC LH, again the antagonist, again the agonist trigger, and the second retrieval. So you do a follicular phase stimulation and you do a luteal phase stimulation. And what they found, that the luteal phase stimulation gives you a better crop of oocytes and a greater percentage of euploid blastocysts. And this is seen in almost 80% of the patients which I have done so far, that if the follicular phase gives, say, just 2 eggs and maybe 1 embryo of medium quality, the luteal phase suddenly gives you 6 eggs and maybe 3 embryos of top quality. So this is, for some reason, the hormonal changes in the follicular phase and the milieu seems to facilitate better quality embryos in the second half. And you can see here, it was statistically significant improvement in the percentage of euploid blastocysts with luteal phase stimulation as compared to follicular phase stimulation. LH supplementation, of course, we know all elderly women will have reduced androgens in LH, so they should be given LH from day 1. All patients with hypogonadotropic hypogonadism, you must begin with 300 of HMG. which works the best for them. Don't give 150 or 225 when you're doing an IVF. Just start with 300 of HMG. Hypo responders means they have very slow growing follicles from day 7. You must add LH for these patients. Poor responders, until now it was thought that addition of LH does not help, but more recent papers show that addition of LH or use of HMG gives you a much better pregnancy rate in poor responders as well. Adjuvants, of course, I don't want to go too much into DHEA and all those things, but what we are eagerly awaiting is the results of the T transport trial, which physiologically we know it is a 72-day shift from a pre-antral to an antral follicle, and that is what this trial is doing, testosterone for 60 days as against the 20 days which most people are using now. Then a down regulation protocol, as I told you, the agonist, which is my personal favorite too, with HPHMG for these poor responders and compared to placebo and testosterone. So we are waiting for the results of this trial to know if testosterone really works for these poor responders. Mild ovarian stimulation, just for the sake of completion, I'm not a big fan of mild ovarian stimulation for poor responders, where you give clomiphene letrozole for 5 days, followed with gonadotropins, low doses of just 100 to 150 IU. The advantages claimed are that only the healthier follicles with more competent eggs will usually develop. So you have a trend to a higher proportion of top quality embryos, even if you get fewer eggs. The milieu is more physiological and therefore optimizes endometrial receptivity, cost saving, avoidance of unnecessary high stimulation drugs, and so on. But again, this is a controversial area, and I personally don't do too much of mild ovarian stimulation. Trigger, very important. Very often you find you had 20 follicles, but you got only 15 oocytes, or you had 15 oocytes, but you got only 5 metaphase 2s, or you had 5 metaphase 2s, but you got only 1 top quality embryo. And that is why the trigger is important. Conventionally, of course, we always use HCG, but that has a higher incidence of OHSS if there are more than 15 follicles. Agonist trigger completely eliminates OHSS, but there's always a concern, as I showed you, with excessive OC pill pretreatment as to the number of eggs and mature eggs that you get. Comparative studies, rec HCG versus urinary HCG, you can see here no evidence of any difference for any outcomes, so both are equally comparable. Agonist versus HCG, of course, lower live birth rates with agonist if you do fresh transfers because of deficient corpus luteum and luteal phase. 250 or 500, personally I prefer 500 for most women, but at least for the obese and high BMI women, you must use 500. Maybe for your slim patients, 250 should be enough. What is the rationale of dual trigger? Dual trigger means I give both the HCG as well as the agonist trigger. Now remember, naturally, in physiologically when we talk, final oocyte maturation is induced, if you remember your basic physiology graph of FSH and LH, by a dual increase of both LH and FSH. Very important. Now, when you give an HCG trigger, you stimulate only the LH peak and there is no FSH activity. The role of HCG is to maintain the LH activity in the luteal phase, but the agonist trigger induces a more physiological peak by displacing the antagonist from the receptors and inducing both LH and FSH surges. So this is very important, and this is why you get better outcomes. And you can see this study here, 2014, when you compare the double trigger with HCG, greater number of oocytes, greater number of top quality embryos, higher clinical pregnancy rates as compared to HCG alone. Even patients where you get a low proportion of metaphase 2 oocytes, when you give the double trigger, you have an increase in the number of metaphase 2s from average of 4 to 6.5. Again, ongoing pregnancy rates are better, number of embryos better, everything is statistically significantly better with the use of the dual trigger. And this was, of course, a study which corroborates the same from 2019 in poor responders. You can see here when they give both HCG and the agonist, they have better outcomes on all fronts with pregnancy rates, live birth rates, and so on. So maybe the dual trigger is better for normal and poor responders. For patients with more than 15 follicles, of course, you cannot give the HCG and you give only the agonist trigger. Monitoring of the cycle, I keep it very simple. I just do TVS on day 2, day 7, and then day 10, maybe one scan in between if she's a hyporesponder. Estradiol almost never required in these days because you're not worried about hyperstimulation. Serum progesterone day 2, which everybody misses out on, day of HCG. If you are planning a fresh transfer, not required otherwise. And in the subsequent frozen transfer cycle, you do it on the day of embryo transfer. So my recommendations for poor responders, pre-treatment with coenzyme Q, resveratrol and ARG9 for 2 months, Testosterone currently we are using 20 days, but once we have the T transport trial, maybe 60 days. First choice protocol for me, long agonist with HP HMG. Second choice, antagonist pre-treatment. Then maybe clomiphene 100, rec FSH with HP HMG combination with the antagonist and a dual trigger. Dual stimulation, really exciting, might soon be my first choice protocol. Fresh transfer if progesterone is between 0.5 and 1.5 on the day of HCG. Frozen embryo transfer if I do not get two top quality embryos in the first stimulation round. Then I will just freeze the embryo, again do a second round. Once I have two top quality embryos, then I'll plan frozen embryo transfer. Luteal phase support, of course, we have to talk a bit about that because we know that in stimulated IVF cycles, you have a high number of corpora lutea, you have supraphysiologic levels of steroids. These have a negative feedback action at the hypothalamus-pituitary axis, which in turn inhibits LH release, which in turn causes luteal phase defect. Also, you have removed a lot of granulosa cells from the follicles at the time of egg retrieval, and this also contributes to inadequate or deficient corpora lutea and a deficient luteal phase. So, of course, everyone knows that you need to support the luteal phase. We are aware of the three common modalities. One was, of course, progesterone, which has been a standard approach. HCG was used and still used by a lot of people because it acts on the corpus luteum, promoting estrogen progesterone release. Of course, no difference in clinical pregnancy rates and so on, but increased risk of OHSS, so not too popular. Use of the agonist, again, not very popular because although there are studies showing it improves pregnancy rate and implantation rate, but sometimes causes surges which are not really conducive to proper implantation. Of course, so progesterone has been the gold standard, and we all know why progesterone needs to be given to support the luteal phase. Coming to which progesterone to use, and now that's where the new developments have occurred. All of us will know that oral is not usually advised because it has very low bioavailability. Micronized vaginal progesterone, vaginally is of course the preferred route, usually as gel or as capsules, sometimes side effects like vaginal irritation. Intramuscular was my gold standard favorite for close to more than 2 decades. But of course, we know it's very painful and causes a lot of injection site abscesses, sterile abscesses, but they are painful. So we've done away with that and mostly switched to vaginal progesterone. But recently, we now have the Lotus trials which show that oral dydrogesterone in a dose of 30 milligrams a day, that is 10 milligrams TID, is sufficient for all patients who have a functioning corpus luteum. That means in all your IUI cycles, IVF cycles with fresh transfer, wherever there is an endogenous functioning corpus luteum, 30 milligrams of dydrogesterone is as good as 200, 400 or 600 of MVP or injections or any other support which you have been using for all these years. So now we finally have an oral substitute for progesterone, which is equally effective. And we know here that they all compare equally well. So you have oral dydrogesterone now 30 milligrams a day. Intramuscular, of course, we used to use 50 in fresh transfers, 100 in frozen transfers. And you have gels, you have insertion tablets, you have compound capsules, you have sustained release, you have suppositories, and most of them it's your personal choice and the patient's convenience as to which to select. Dydrogesterone, why is getting more and more popular? Because we know that the equivalence dose is 10 to 20 times lower than progesterone, and we have enough of studies on the safety and tolerability profile in pregnancy for both the mother and child. It also has the added advantage of immunomodulation, which especially helps in patients who have had a history of early pregnancy losses and in threatened aborters. So we know that oral dydrogesterone, even in frozen embryo transfer cycles, is as effective as either intramuscular or vaginal supplements. And we are just awaiting a few trials to be published now as to what is the correct dose for these patients in frozen transfer cycles. Like I told you, if there is a functioning corpus luteum, 30 milligrams is enough. But in frozen transfer cycles, most of the time we have suppressed ovulation. There is no functioning corpus luteum. So we need to know whether 30 or 40 or even 60 is what should be ideally given to these patients. So of course, there was a study where they compared 50 milligrams intramuscular versus oral dydrogesterone, 40 milligrams versus 400 milligrams, 800 milligrams of vaginal for luteal phase support in artificial frozen embryo transfer cycles where you don't have a functioning corpus luteum. And the study found comparable pregnancy and live birth rates in all three groups. Miscarriage rates were not different, and all the pregnancies were intrauterine. So apparently, 40 milligrams of dydrogesterone might be equivalent to all the my MVP that we have been using. And Australian and New Zealand guidelines also say that dydrogesterone is currently the best option for luteal phase support. And even the ASHRAE guidelines say that dydrogesterone is probably recommended for luteal phase support. But again, we are awaiting Lotus phase 2 and phase 3 trials to confirm these findings. Finally, of course, I have to also talk a bit about endometriosis. And not every patient needs IVF. We know that surgery has excellent results. And of course, all of you know that finally, if the patient ends up with failed IUI cycles or recurrent endometriomas, which you don't want to keep operating, or she has bilateral endometriomas, or the age factor, or a reduced AMH and AFC, or she has adenomyosis with tubal block, with male factor, obviously she needs to go in for IVF. Now, please do not operate on endometriomas because the patient is going for IVF. It is not indicated. You only need to operate if, like the classical criteria given by Velasco, rapid growth, suspicious features, pain, potential for rupture during pregnancy, if you can't access follicles, which I've never got that problem before, or if they are bilateral and more than 3 centimeters, which was recently added by Donez. So we know now that in infertile women with endometrioma larger than 3 centimeters, there is no evidence that cystectomy prior to IVF improves pregnancy rates. So please do not operate. They already have a reduced ovarian reserve, and any kind of surgery will only reduce this reserve even further. What about affecting oocyte quality, and what about affecting embryo quality? We all have read these repeated papers that there is a lot of ROS generation in endometriosis patients, which hinders oocyte maturation. They have lower cytoplasmic mitochondrial content, altered morphology, and this negatively affects nuclear maturation and so on. But we now have this huge study from 2020 comparing endometriosis oocytes with controls, and on all fronts, fertilization rates, cleavage rates, percentage of top quality embryos, blastulation rates, everything is the same. So there is no difference when it finally comes to your embryology in the laboratory. The perceived lower ongoing pregnancy rates are probably because of altered endometrial receptivity rather than affecting oocyte or embryo quality in these patients. So this is very important, and that is why it is important that we have to now try to improve endometrial receptivity for these patients. And the best way to do that is to do a frozen embryo transfer rather than do a fresh embryo transfer. So again, you can see here, when you actually compare live birth rates, 14% lower in stage 3 and 4 endometriosis as expected, but not statistically significant. And this is usually because you have fewer oocytes, because a lot of these patients have very low AMH levels and are also very poor responders. And you can see here this large study which compared stage 1, 2 endometriosis versus stage 3, 4 versus tubal factor infertility, and they did not find any difference in any of the parameters of gonadotropin consumption, number of oocytes, fertilization rates, and so on. You can see a clinical pregnancy rate 40, 36, 42.3, so slightly lower in stage 3 and 4. Again, that's because of fewer oocytes in these patients with very low AMH. The presence of an endometrioma, again, you can see does not affect, red is the affected ovary, blue is the normal ovary, and most of the parameters are the same. So even if one ovary has an endometrioma, small endometrioma, it does not affect any of the parameters which are important for IVF, and also does not affect oocyte developmental competence. But if you have a large endometrioma on one ovary, as this study showed in 2017, obviously you will get fewer oocytes from that ovary because of the excessive compression of the ovarian tissue, or because it's already been there's too much of pressure all around, and therefore you might get fewer oocytes, which then would translate into lower cumulative live birth rates. Very important slide. A lot of people love to give 3 months of suppression prior to IVF. Please look at this Cochrane data analysis from 2019. And contrary to previous findings, it is uncertain whether long-term 3-month agonist therapy impacts live birth rates in endometriosis patients undergoing IVF. So please, 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 we don't need to suppress them for 3 months. You just need to do a good protocol, get adequate number of top quality embryos, freeze them, do a good frozen embryo transfer without 3 months of suppression, and you will get very good pregnancy rates. So again, ASHRAE guidelines in 2014 again confirmed to the same that excessive suppression of ovarian function is not required in these patients. If you are planning fresh embryo transfer, then agonist is better because the down-regulatory effects remove a lot of the negative effects which are associated with endometriosis. But in today's times, when we are doing a lot of frozen embryo transfer, the antagonist protocol is equally effective. And you can see here, especially in poor responders, you might get, as this paper showed, a few more number of oocytes. Most important slide, of course, we know that endometrium receptivity is highly affected in endometriosis, maybe because of defective maturation and inappropriate biochemical markers, supraphysiologic levels, and so on. And therefore, frozen embryo transfer is definitely better than fresh when we talk specifically of endometriosis. And this huge study from 2018, you can see cumulative ongoing pregnancy rates, fresh transfer group 17.8%, frozen embryo transfer group almost double at 35% with statistical significance. So we know for sure that frozen is the way to go for endometriosis. Should you do freeze-all for all endometriosis? Yes, this study again from 2019 showed clearly with freeze-all, you have much better implantation rate, statistically significant higher clinical pregnancy rate, and statistically significantly higher live birth rate with freeze-all as compared to fresh. So concluding for endometriosis, these are of course challenging patients because a lot of them are also poor responders with low AMH, fewer oocytes, possibly lower fertilization, but final live birth rates are the same. Clinical pregnancy rates are not different from other causes. Live birth rates are not different. Cumulative live birth rate will be lower in severe endometriosis or if you have a large endometriomas because you get fewer number of oocytes. So you have fewer number of embryos for freezing. So you have fewer number of frozen embryos for transfer. And so your cumulative live birth rates appear to be lower. Adjunctive medical treatment requires further RCTs. At the current moment, no evidence for 3 months of suppression. And again, surgery prior to ART is not required and in fact might do more harm by reducing an already reduced ovarian reserve further without improving pregnancy rates. And of course, this is just one slide I picked up a few minutes before I was about to talk today, and that is on hypogonadotropic hypogonadism, which again, very important paper which I just came across, that this category of patients is usually has very good quality oocytes and embryos. So you don't need to put more embryos when you're dealing with a hypogonadotropic hypogonadism. So of course you will use only HNG or a combination of REC FSH and REC LH from the beginning because they have very low levels of FSH and LH and they need both from the beginning. And you can see here, you have to do a freeze-all for these patients. Don't do fresh transfer and just put in a single embryo. No need to put double or triple embryos. And you can see here, fresh single embryo transfer live birth rate 27%, frozen single embryo transfer. If one embryo, you get a clinical pregnancy rate of 65 and a live birth rate of 50, which is the same as any other category of IVF undergoing double embryo transfer. So the take-home point from this slide is to do a single frozen embryo transfer. Start with 225 or 300 of HMG and you will achieve success very quickly with most of your patients of hypogonadotropic hypogonadism. So of course, with that we conclude because we are almost at the end and just have about 7 minutes left for questions. Judicious use of agonist and antagonist. Don't give up the agonist. As I showed you, the agonist gives you a more uniform cohort, gives you more oocytes even in poor responders as compared to the antagonist, especially if you use HP-HMG, and gives you higher pregnancy rates, as I showed you so many studies for Poseidon's 1, 2, 3, and 4. Pre-treatment, very important in antagonist cycles. Don't neglect this area. Avoid prolonged OC pill use. You have many other methods, estradiol, norethistérone, antagonists for pre-treatment. Progesterone levels are important not only on day of HCG but also on day 2. Agonist trigger will not work with excessive LH suppression and often results in not getting good oocytes in your egg donors and high responders who have been on prolonged OC pills. Selecting the right starting dose is very important because later on titrating doses on day 7 doesn't help. High responders, HP-HMG needs to be seriously looked at in the light of the Megaset HR trial. Dual stimulation seems to be very promising for poor responders. Coenzyme Q and testosterone are proven to help in poor responders. Luteal phase, of course, my MVP being our gold standard, but dihydrogesterone needs to be seriously looked at. So with that, ladies and gentlemen, I've tried to cover as much as I could. This could go on and on and on, but maybe whatever has been left out today, we'll cover next Friday when I talk about more about progesterone and freeze-all strategies. So once again, I'd like to thank the entire team of Intas for providing me with this opportunity to connect with all of you wonderful people. And I think we can take a few questions. Thank you so much.
Thank you, sir. First of all, for giving your time and giving such a good practical with practical points and take-home messages and important for their practices. They must have been benefited with this. There are many questions. I'll be taking some of them. First of all, they are telling very nice, high-quality talks. Thank you, sir, for your time.
Thank you. Thank you.
Yes, sir. So they are asking. Sir, how long are you using HPHMG in hyper-responders?
I have been using for the last 3 years, but I was not aware of the results of the Megaset HR trial. I had very similar observations that there is something in it that is giving us more top quality embryos. In fact, I have been ordering a lot of Menotas also from Intas, which is also a similar drug to Menopure. And definitely there is a story in the use of LH in PCOS patients as well. So of course, this is a huge study, so it's not too debatable. And experience has been really good so far.
In case of pre-treatment with OC pills, if we give for 10 days, starting from day 2 of cycle, does it mean we start stimulation from a mid-cycle?
Yeah, if you use OC pill from day 2, effectively you are keeping her on day 2 till you keep giving the OC pill. So suppose you give for 10 days, take her to day 12, then you will stop, then day 17, she will again bleed. So that is again day 2. It is not mid-cycle, that is again day 2.
Mm-hmm.
All you achieved is your scheduling, your programming, your postponing, and trying to get a uniform cohort and getting a synchronous follicles. So that's what you're achieving. So it's not actually mid-cycle, you are just scheduling or pushing the periods forward. The cycle changes then for that woman.
Right, sir. While deciding the type of protocol, can you please give any clue based on AFC and clinical guidance on the dose of gonadotropin based on the age and BMI?
Yes, of course. That is what I showed, that the dose deciding will depend on age, BMI, AMH, AFC, previous response to treatment, and the presence of associated endometriosis or PCOS. So you have to take all this into consideration when you decide a dose. But as a rule of thumb, it's a good question, because if you don't want to apply too much of your mind to every case, normal responders stick to 225. It works beautifully for most of them. Poor responder, Poseidon group 1 and 2, you can go from say 225 to 300 max for a very high BMI patient. For Poseidon 3 and 4, just 150 is enough because they don't have follicles, so giving 450 doesn't help. If it's a high BMI, maximum 225. For high responders, 150 to 200 as per the BMI. So a thin PCO, 150, high BMI, 225 or 200 should be the max. So this is how you can have fixed doses based on their basic profiles.
Thank you, sir. And sir, they are asking, are you doing fresh transfer for poor responders?
No, so that I showed in that last concluding slide, that fresh transfer, if you get 2 top quality embryos in your first stimulation, whatever you have done, except the dual stimulation. In dual stimulation, you can't do fresh transfer, obviously, because you are also stimulating in the luteal phase. But for all other categories, suppose you've done an agonist or an antagonist and you get 2 top quality embryos, and on the day of HCG, her progesterone is between 0.5 and 1.5. So you don't have low progesterone, you don't have high progesterone. Fresh and frozen will give you the same pregnancy rate. But if you do not get 2 top quality embryos, both the embryos are very poor in quality, you should tell the patient that this is not going to work. It's better to either discard the embryos if they're really bad, or freeze them and keep them as a backup plan. But let's do a second round of stimulation, try to get 1 or 2 top quality embryos, and then do a good frozen transfer. In that case, it works psychologically much better because patient doesn't go through all the negative emotions of a failed cycle. So embryo pooling, if you don't get enough top quality embryos, but if you get 2 and the progesterone is well within normal limits, fresh and frozen will give you the same results.
Correct, sir. And sir, do you use dual trigger for all normal and poor responders?
Yes, we do. So normal and poor, we always give dual trigger. For high responders, for obvious reasons, you cannot. You have to only give the agonist trigger.
And the last question, sir, will you operate on bilateral endometrioma more than 3 centimeter before IVF?
Only if, as per Velasco's guidelines, it has any of the features which are suspicious, you are suspecting a malignancy, or if you have severe, unbearable, excruciating pain, or you feel that it might rupture during pregnancy. So he has put down those 6 criteria. Otherwise, I would not advise repeated surgery from the point of view of accessibility I'm sure Manish would also agree. This is more of a textbook thing, for a good egg pickup person. He can go through the endometriotic cyst and retrieve most of the oocytes. So it's not really a technical difficulty, which should be an indication for surgery. So basically, I would not like to operate if it is just as a pre-IVF procedure to improve outcomes.
Correct, sir. So thank you on behalf of INTAS and all the viewers. I thank you, sir, for giving us time and giving us a wonderful lecture. It was a really, really a master class. Thank you, sir.
Thank you so much. Thank you.
Dr. Salama, would you like to tell something?
Yes, thank you, Dr. Jatin. It's very important and full of updated informations. I think it will change some of our practice in infertility treatment towards better results. You highlight the use of the importance of stop use of ossiples before both protocols, which is very common use in our countries and other countries. And also, you speaks about you speak about the importance of the P4 measurements in CD2, which is important also. I wanted to ask about the progesterone use for down regulation. What is the indication? Only the cost or unavailability of the antagonist or other indication?
The main indication they have given right now is that you do away with injections. So if it's an antagonist protocol, it is 6 less injections. If it's an agonist protocol, it is 25 less injections. And you have an oral option to an injectable option. So right now, that's the only major advantage which is claimed. But as I showed you, if you give MPA to prevent a premature LH surge, you cannot do a fresh transfer because it will affect the endometrium, the progesterone. So you have to do a freeze-all strategy. And there is one paper initial that shows that it probably affects oocyte quality as well, because they showed in a oocyte donor program that the recipient pregnancy rate was not as good as when they used an antagonist protocol. But again, there is a very recent paper in ESHRE which shows the same outcome in egg donation program as well. So we need more trials basically on the use of MPA as a routine and to completely replace agonist and antagonist once and for all. So we don't have that much evidence as yet.
Yes. So in case suboptimal freezing ability, it is not suitable at all. Regarding the use of costing, what is if our freezing lab ability is suboptimal? Is it better to do costing and the trigger with the fresh transfer or agonist trigger and freezing?
No, but if your freezing is not optimal, of course, the best option is agonist trigger and freeze all. If you don't have that and you want to do a fresh transfer, and if she say has 15 to 20 follicles, you could do an add back HCG, 1500 IU HCG on the day of egg retrieval and proceed with your fresh transfer. Posting doesn't really work. So posting just helps you to reduce estradiol levels, but that itself impairs the outcome of your final pregnancy. So it doesn't really work. You don't get good oocytes and it doesn't give you optimal pregnancy rates. So ideally, if at all, that's why the only slide I showed was on the add back HCG. That's the only thing which will restore your pregnancy rates to 50%. If you are okay with a 15% incidence of OHSS, a lot of it would be pregnancy induced OHSS, so could become severe sometimes. If you are okay with that and you have counseled the patient for that, then only you can go ahead with fresh transfer. The best third option is you give your HCG trigger. Some people say, okay, instead of 10,000, we'll give 5,000 or 3,000, but that doesn't really reduce the intensity of OHSS. You pick up the oocytes, freeze the embryos, but you then continue with cabergoline or agonist so that she just has 7 days of early OHSS and not the more life-threatening late OHSS. So these are 2 or 3 things which you could do. But the best is again, because
so also it is a message for us because we use the costing a lot. So also the higher dose for stimulation and for responder is 225 or 300 maximum.
Maximum. For Poseidon 1 and 2, it is 225 to 300. Poseidon 3 and 4, it's 150 to 225 as per BMI. It's lower for Poseidon 3 and 4.
Yes.
For Poseidon 1 and 2, 225 to 300 is okay.
So no place for 400 or more.
No, that too many studies which clearly show that more than 300 doesn't work for anybody. In fact, Blocky-Ilto goes to the extent, as I showed his slide, that 225 is the max for everybody. But personally, I still give 300 to a lot of patients, so I think it's okay.
From your experience and point of view regarding the use of gonadotropins, regarding the cost of gonadotropins or the company, is it effective? You see, for IVF, we're afraid of the results. So we usually choose the costly drugs and the patients can't offer.
No, not really. I
Is
think
it
with the
because-
with recombinant FSH, that problem is not too much anymore because most of them are on par with each other. They give you a very good response. They don't have any batch to batch variability. Results are consistent. So most of the rec FSH brands are good. With urinary, even at least in India, for the last 4 or 5 years, we don't really see bad batches like we used to see 10 years ago. So the batch to batch variation and all the textbook things which we read may not be very applicable today, but there are some brands which are always your favorites, and you have this perception that they give you better pregnancy rates. But as far as I feel, I think all the rec FSHs are on par with each other, most of them, the recombinants.
So the origin is not effective, especially you mentioned that HMG is with a good result as the
Yeah, so that is not comparing rec FSHs. So that is a different molecule totally. So
except for
HPHMG
the
is,
number,
yeah. So
except
in
for
that
the
we have
number of
only two
follicles.
brands. Yeah, HPHMG we have only two brands
Yes.
right now. Yeah, where you have HCG driven LH activity.
Thank you very much. Thank you.
Thank you. Thank you.
Thank you, sir.
You are muted, Sona.
Oh. Thank you, sir, Jatin sir. Now already we have Dr. Manish sir, so we'll start with the next lecture. Over to you, sir.
Thank you very much. I will start my second talk now. It is focused on three aspects where I will be speaking on. This is third-party reproduction first, then we look at the role of hormonal testing in infertility, and then talk something about various adjuvants as to what is their role and when should we use these adjuvants in infertility practice. So third-party reproduction refers to a process where a man other than the husband will provide the sperm, or woman other than the wife provides eggs, or when a woman other than the wife provides a uterus to carry the child. It could be either one, two, or all three of this. Now, this is limited primarily to reproductive process only. So it is only restricted to achieving a pregnancy. Once the child is born, that child becomes legally the child of the commissioning couple, and the donor of sperm, egg, or the surrogate then does not have any linkage or cannot claim to this particular child. So there are certain terms which we need to look at when we are talking about third-party reproduction, and that is the donor. That is the person who gives the gamete, either the sperm or the egg. The gamete donor is the one who provides this to the couple, and surrogacy is the arrangement by which a woman agrees to carry the pregnancy through ART and then hands over the child to the commissioning couple. Uh, so what is included in this is sperm donation, ovum donation, embryo donation, and surrogacy. These are the four types of third-party reproductions that I will be talking about. So the first is ovum donation. So what happens in this is that there is another woman who is stimulated to produce the eggs. Sperms come from the husband, and the resulting embryo is then transferred back into the wife. So the donor of the egg is the one who gives the eggs. Now, this is indicated in two situations. One is women who have non-functioning ovaries, and second in women with functioning ovaries. So in the first category, it would be women who have premature ovarian failure, who have ovarian agenesis, who have undergone bilateral oophorectomy, or those who want to have a pregnancy post-menopause. Now, all these four category of women, since the ovary is non-functioning, have no chance of a pregnancy with their own oocyte because their ovaries have stopped producing oocytes. On the other hand, in women with functioning ovaries, there is a possibility for them to have a pregnancy with their own oocytes, but we would still advise, or they would still require donor oocytes if they have had repeated failed IVF cycles due to poor oocyte quality, in spite of changing the protocols or whatever you could, or in extreme cases where the ovaries are completely inaccessible, or when there is a risk of an inheritable genetic disorder, or in very rare instances where there are contraindications to have induced ovulation, like in those with von Willebrand's disease or other clotting disorders, and in survivors of malignancies who have been treated with either irradiation or chemotherapy, and their ovarian function has been significantly reduced. So in both this category, with and without functioning ovaries, you would resort to egg donation. Now, how do you select an oocyte donor? We need a woman who is young with a good ovarian reserve. In addition to this, every country will have their own guidelines on who should be allowed to donate eggs. For example, the current proposed ART bill in India mentions that the donor should have at least one live child with the minimum age of 3 years. But from a medical perspective, it is not necessary for the woman to be either married or have a child of her own. It is not a medical requirement. Of course, she has to be counseled properly and has to be psychologically sound, should not be having any obvious illnesses or hereditary genetic disorders in the family. So this donor, again, whether it should be anonymous and confidential or whether the identity should be revealed, is governed by national laws. And in India, it has to be anonymous and confidential. The woman could donate either because of altruistic reasons, then it could be a family member, or it could be non-altruistic for monetary compensation. Again, this is dictated by the local regulations and law. And this woman should just do is approach an ART clinic. Before we start the process of egg donation, an informed consent of the couple, the donor and the husband, both is required. Uh, we carry out all the blood tests that one would have done for a patient. And in addition to this, we also screen for common disorders like thalassemia. Again, regional things in certain countries, it would be wise to screen for sickle cell anemia as well. So this depends on the local conditions. And these are a sample consent form which we use in India, where all the details have been explained and the consent is taken. There is also a template as to what information regarding the donor would be shared with the patient. And as you can see, everything except the name and the identity of the donor is shared. The age, the marital status, occupation, history, all the blood reports. So everything except the identity of the donor can be shared with the couple. The steps include, first is selection of the donor and the recipient, and we match the donor to the recipient. The donor undergoes appropriate stimulation. So Dr. Jatin would have covered, but the fundamental differences in conventional stimulation and a donor stimulation is, one, that we should not use overstimulation. We just need between 10-15 oocytes. It should always be an antagonist cycle with an agonist trigger. You should not use a long agonist protocol for a donor, because putting the donor at risk of ovarian hyperstimulation is not advisable. So one should always use an antagonist protocol with an agonist trigger. We then collect the sperms, fertilization, and embryo formation. At the same time, we also need to synchronize the donor and the recipient. There are two ways in which we can do the transfer. One is to synchronize the cycle so that the recipient gets her periods before the donor, so that whenever the donor pickup is done, the recipient is ready. We prepare the recipient as we do the preparation of a frozen embryo transfer HRT cycle by giving her sequential increasing doses of estrogens. And if you are not able to synchronize, the second option is to do a segmental cycle that you stimulate the donor, create the embryos and vitrify the embryos, and then prepare the recipient at their own convenient time and you do the embryo transfer. Now, in this scenario, since the recipient is prepared by an HRT process, she will need this particular hormonal replacement therapy till the placental shift happens at around 12 weeks of pregnancy. So what we do is we match the donor with the couple as far as possible. And the common things that we match is the height, skin color, eye color, hair color. It is preferred to have a compatible blood group, but again, medically it is not necessary, but this is to prevent awkward movements when the child has a completely different blood group. We should carry out hormonal profile like a thyroid and AMH if you want to measure ovarian reserve. Otherwise, we do the normal serological markers and then we start stimulation. We do a complete checkup to rule out medical disorders and counseling. So these are the information that is being shared: height, weight, ethnicity, skin color, educational qualification, etc., etc. Some recipients want a donor of a particular type, then we should make the efforts to match that, because other than revealing the identity, everything else is what we can and should do. The couple who is undergoing the process of egg donation also needs complete evaluation, like in an IVF cycle, the virological markers, endometrial assessment, semen analysis, etc., so that at least her endometrium is not pathological and would be accessible, would be ready to accept the embryo that we are transferring. So the donor is stimulated from the second day of her menstrual cycle in an antagonist cycle with an agonist trigger. And we do the standard simulation and the egg collection after the agonist trigger. Normal, one would like to give at least 7 or 8 mature oocytes so that you would have at least 2 good quality blastocysts available. If you have more, it is fine. Then we can vitrify the balance embryos. But 7 mature oocytes is the minimum that a recipient should get. The endometrial preparation of the recipient again begins from the second day. It could be a natural or a modified natural, but typically we do the hormonal replacement therapy where we prepare the endometrium with increasing doses of estradiol. Once the endometrium is 8 millimeters or more, we add the progesterone, and then we do the embryo transfer on day 3 or 5, depending on whether it's a day 3 embryo or a day 5 embryo. So this is how we do estradiol. It could be estradiol valerate, estradiol hemihydrate. We start from the second or the third day. We wait for about 8 to 10 days and aim for an endometrium of more than 7 millimeters, and then we add the progesterone. After the embryo transfer, the same luteal support of estrogen and progesterone is continued, as there would be no corpus luteum. A beta HCG test about 2 weeks later, and if positive, continue this till the pregnancy is around 12 weeks. The second area in third-party reproduction is sperm donation, and here the sperms come from a man other than the husband. This could be a simple IUI where just the sperms are injected, or it could be an IVF where the wife's eggs are removed, create the embryos, and embryos are then transferred back into the wife. So again, the indications are: one, when there are severe problems in the male, it could be azoospermia where there is complete absence of sperm production, or when the couple cannot afford IVF, or when there is severe oligospermia, sometimes seminal fluid abnormality. It is also used for single women, unmarried single women who want to desire a pregnancy if it is legally permissible. And this is also required for same-sex couples, female, if it is legally allowed in your particular country. Now, the selection criteria for semen donors are by and large similar, that they are of good health status and absence of known genetic abnormalities. The only difference is that the upper age for a sperm donor is typically 45 because quality of sperms do not decline so drastically as that of the egg. We need consents of both the partners. Again, established fertility is not a medical necessity. We do a proper psychological evaluation and counseling. And again, in most countries, this is anonymous. But again, as I said, this will be governed by local laws. The procedure is similar to the standard IVF with ovarian stimulation of the wife, egg collection, and instead of using the husband's sperm, you fertilize these eggs with the donor sperms and you proceed with the embryo transfer as you would have done in a normal IVF cycle. The third category is for embryo donation, where both the sperms and the eggs come from a third party. An embryo is created, and the embryo is then transferred into the wife. So, this is typically for couples where there is an indication for sperm donation and egg donation, where you have a combination of both, or when you have multiple failed attempts following all cycles and nothing has worked, maybe you could try with embryo donation. Now, how is the embryo formed? So, this embryo, for the purpose of embryo donation, is formed using the sperms of an anonymous sperm donor and an anonymous egg donor. In India, we cannot use surplus embryos of a patient for the purpose of embryo donation. These embryos can only be used for the couple, but again, this is dependent on local regulations and laws. The process is very simple. It is like a frozen embryo transfer. You prepare the endometrium, add the progesterone when the embryo is good, and then you perform the embryo transfer. Then we come to the last aspect of third-party reproduction, where the embryo of the couple, this could come from the wife's egg, husband's sperm, or it could also be donor sperm, or it could also be donor eggs. But this embryo is then transferred into another woman who is called a surrogate. So this is indicated in couples where the woman has absence of uterus or has large uterine pathologies or has undergone hysterectomy for various reasons, or a woman who has suffered from unexpected repeated miscarriages, especially because of severe types of cervical incompetence, repeated IVF failures due to a non-receptive uterus, very thin or poor endometrium, women who, because of their medical conditions, are not advised to become pregnant, and for women whom the prospect of carrying a pregnancy to term is remote for any medical or obstetric reasons. The steps are you do a proper selection, you create the embryos, and then you source a surrogate. Now, this is again dictated by local regulations as to who can act as a surrogate and how do you find a surrogate. But this requires intensive counseling of the surrogate because this is a key factor. She will have to take all the medications and carry the pregnancy to term and then hand over the child at birth to the commissioning couple. So what we need to do is synchronize the menstrual cycle of the surrogate with the genetic mother and do the appropriate embryo transfer. A lot of legal documentation is required. There needs to be law covering as to the whose name would go on the birth certificate of this child, because it is the surrogate mother who is delivering the child, but she is not the biological mother, and how and when should the custody of the child be handed over to the commissioning couple. So all these legal formalities, proper financial contracts need to be signed because the surrogate is by and large doing this for financial reasons. So what compensation should be given, it should be all documented and properly signed. A surrogate is typically below the age of 35 so that we are not subjecting her to pregnancy complications. We need the consent of the surrogate's husband as well. All this screening that is involved pre-IVF, including psychological assessment and medical assessment, should be carried out. We need to evaluate her endometrium, a proper serology, and an ultrasound. So this is in brief about what is involved in third-party reproduction, and how do you go about doing it. I will now take you through the second part of my talk, where I will talk about the role of various hormonal testing for infertility. I will talk about the following hormones: TSH, prolactin, FSH, LH, estradiol, AMH, and androgens. What is the role of testing each of these hormones in an infertile couple? Let us first understand the menstrual cycle. Now, each hormone, FSH, LH, E2, and progesterone, is secreted in different fashions during the entire menstrual cycle. FSH primarily for follicular recruitment, estradiol in response to this recruited follicle, responsible for endometrial proliferation, LH primarily for the ovulation trigger and release of oocytes, and later on in the luteal phase, both estrogen and progesterone for preparing the endometrium for accepting the embryos. Now, TSH is the hormone which is produced by the acidophilic cells of the anterior pituitary, and its relevance in infertility is because it is involved with ovulation. If the woman is hypothyroid, there is increased release of thyroid releasing hormone from the hypothalamus. This also leads to stimulation of prolactin release and affects the pulsatile secretion of GnRH analog, and hence inhibits the secretion of the pituitary gonadotropins and causes anovulation. So all these hormones are interlinked at the level of hypothalamus and pituitary, and this is why we need to check and monitor and control all of them. Now, TSH sample should be ideally measured in fasting stage early in the morning. The normal range in the non-pregnant state is between 0.4 to 5 milli-international units per ml. In the first trimester, it should be below 2.5, in second up to 3, and in the third trimester, it may be up to 3.5. But there is some evidence that despite 95% of the population having TSH below 2.5 MIU, there is no evidence to support treating non-pregnant patients with a TSH between 2.5 to 5. If the woman is planning to conceive, it is okay. But in a non-pregnant woman who does not want to conceive, it is not really wise to treat these patients with thyroid, because overtreatment could actually lead to bone loss. The second aspect also, whether that even for pregnant women, whether we should use this low cutoff of 2.5 instead of 5 is also subject to some amount of controversy. But even though the evidence is weak, most professional guidelines recommend that this should be treated. The second issue is, should we look for anti-TPO antibodies in a woman who has infertility or recurrent miscarriages? Now, there is fair bit of evidence that this thyroid autoimmunity is associated with recurrent pregnancy loss, and some evidence that it is also associated with infertility. So if you find this, one should treat them with minimal doses of thyroxine, especially if the TSH is over 2.5 MIU per ml. Now, when would you evaluate TSH? Ideally, in all women planning to pregnancy, but more so if she has got menstrual irregularities, anovulatory cycles, or has unexplained infertility, or if she presents with symptoms of hypothyroidism like weight gain, loss of appetite, fatigability, dry skin, etc. You should evaluate because it is very easy to treat, and a simple levothyroxine tablet will restore the thyroid function, and if she is anovulatory because of this, she will become ovulatory. Second, if the woman is hypothyroid, they need higher doses for ovulation induction, and treating thyroid reduces their drug requirement. And secondly, should a hypothyroid woman become pregnant, it also leads to higher adverse pregnancy events like abortions, preterm delivery, anemia, PIH, and issues related to neurological development in the fetus. The second hormone is prolactin, and this is a slightly tricky one. It is secreted by the acidophilic cells of the anterior pituitary, And its role in female infertility is that if it is elevated, it can lead to a deficient luteal phase, anovulation, and sometimes also hypogonadism. So hyperprolactinemia could result in anovulation and amenorrhea because of the disturbance with the hypothalamic GnRH pulse rhythm. The normal value of prolactin is below 20. If it is mildly elevated between 20 and 50, it essentially causes poor folliculogenesis and an abnormal luteal phase. If it is moderately elevated between 50 to 100, it causes oligomenorrhea or even amenorrhea. And if it is severely elevated, it causes frank hypogonadism and complete amenorrhea along with osteopenia. And whenever it is 100 or above, a CT or MRI of the brain should be carried out to rule out pituitary adenomas. Now, prolactin sample is usually measured in fasting because the levels could be increased after food intake. A single elevated value should always be reconfirmed, and it is sometimes wise to take pooled samples taken 30 minutes apart. And if it is more so, if it is only modestly elevated, you should do a multiple serum assay or pooled sample assays. Any kind of breast examination will also raise this level. So if you have done a clinical examination in the OPD, don't ask the patient to give a prolactin sample immediately. Stress, exercise can also cause elevation, and a variety of drugs. Simple drugs like antacids also lead to elevated prolactin. So take a detailed history of any drug ingestion, because the patient will think that all she's taking is an antacid and she may not give this history. You should ideally test it more for patients who have menstrual irregularities, anovulatory cycles, galactorrhea, headaches, or visual disturbances, and the normal range is between 2 and 20. This is present in nearly up to 17% of women with infertility. It is very easily corrected with a dopamine agonist, either cabergoline or bromocriptine, and patients start to resume ovulatory cycles within 6 weeks of starting their therapy, and the results are fantastic. If such a woman becomes pregnant, there is yet no evidence of teratogenicity of either cabergoline or bromocriptine, and there is no risk of abortion or multiple pregnancy. However, if she does not have a tumor, we can stop. And if she has a microadenoma of less than 10 millimeter, we could still discontinue. But if the adenoma is bigger than 10 millimeters, it should be continued during pregnancy to avoid the risk of tumor expansion. All patients with high prolactin treated with drugs during pregnancy should undergo visual field testing during the pregnancy to see that the tumor has not increased. The third hormone is FSH. Now, this is again produced by the anterior pituitary in response to GnRH, and this is the primary hormone which is responsible for folliculogenesis, as it rescues the cohort of follicles from that particular cohort from undergoing apoptosis. It is important that this is always measured in conjunction with estradiol to interpret the results accurately, because an elevated estradiol will falsely suppress the FSH level. It should always be under basal conditions, that is on the second or the third day of the menstrual cycle, and the normal level is between 3 and 20 international units per liter. There is a lot of variability in FSH, and hence it is many a times repeated. And if you only have a single elevated level in a young woman, we should repeat it before coming to any conclusions. The diagnostic criteria is that the ideal level should be 50% below the upper limit. So if the normal value of the test that you're doing is up to 20, a normal level is about 10. Anything below the 50% of the upper limit suggests reduced ovarian reserve. But why do we need to evaluate? Because as I had mentioned in my earlier talk, AMH is a much better marker of ovarian reserve. So the indication of FSH to test for ovarian reserve is now decreasing. But there are two other indications where this is of value. One is to evaluate the cause of anovulation, and second is to monitor pituitary downregulation when you're using the long agonist protocol. Because you classify anovulation into the various WHO types based on the FSH and E2 levels. If both are low, it is hypogonadotrophic hypogonadism. Both are normal, it is normogonadotrophic, normally PCOS. And if the FSH is high and the estradiol is low, it suggests premature ovarian failure. So for diagnosing the type of amenorrhea or anovulation, measurements of FSH is important. For using it to confirm pituitary downregulation, estradiol alone is sufficient, and we generally do not measure serum FSH to confirm pituitary downregulation. A thin endometrium and a low estradiol is more or less sufficient. We then come to the measurement of LH, and this is the trickiest of all the hormones. When do we measure it? Do we measure it? And what is its role? Now, the primary action of LH was believed that this is responsible for releasing of the oocyte at the time of ovulation, and the LH surge is followed by ovulation approximately 36 hours later. But we now have evidence that the theca cells express LH receptors from the very early follicular genesis. So till this follicle is less than 5 millimeters, it does not have LH receptors. But the moment the follicles become more than 5 millimeters in size, nearly 80% of them exhibit LH receptors. And the moment it increases beyond 10 millimeters in size, most follicles have LH receptors. So this means that they possibly have some role even in early follicular genesis. And this is what we see, that in poor responders who do not respond to FSH alone, addition of LH improves the outcome. The normal range in follicular phase is low. In the ovulatory phase, you see the surge, and then it has a low level in the luteal phase. But you can see the ranges, and this creates a problem as to how do we interpret the values. So this brings us to the main question: is when do we evaluate LH? One role is to measure serial LH levels, either through urine or through serum kits, to predict the day of ovulation. And we need to start monitoring this approximately 2 or 3 days prior to the expected day of ovulation. So this is of importance. It can also be used in conjunction with FSH to confirm the diagnosis of hypogonadotrophic hypogonadism, but its role to confirm pituitary downregulation is not very important. At once upon a time, it was used to confirm the diagnosis of PCOS because it was thought that the ratio of LH to FSH should be more than 2:1. But after the introduction of Rotterdam criteria, this has become outdated. To diagnose hypogonadism, yes, in conjunction with FSH. For pituitary downregulation, again, estradiol alone is sufficient, so you do not need to measure it. And to detect a premature LH surge, again, not important because the cycles are always suppressed or downregulated, but it can be measured to predict the day of ovulation. So now the role of measuring LH is very much restricted to these ovulation detection kits. What about estradiol then? Now, this is the main hormone which is secreted by the granulosa cells in response to FSH, and it gradually increases in the first 2 weeks till it falls just prior to ovulation. Now, this again could be, if you're using it to measure the ovarian reserve, it should be measured on the second or the third day in conjunction with FSH. But if you're doing it to measure the ovarian response, it can be measured on any day. And the typical value of estradiol is between 150 to 200 picograms per ml per mature follicle of more than 16 millimeters. So you measure it typically on day 2 or 3 along with FSH to measure ovarian reserve, but AMH is a better option. It is used to monitor ovarian response and to confirm pituitary downregulation in an agonist cycle. But when it comes to monitoring an ART cycle, today ultrasound has become the main tool to measure ovarian response. Estradiol levels are only measured if, in exceptional cases, we need more additional information. For example, in extreme poor responders or in patients who are at risk of hyperstimulation syndrome. So it is primarily used for non-responders or fast responders. Then we come to the role of progesterone, and this is the hormone which is produced by corpus luteum. It is low in the follicular phase, below 1.5, and in the luteal phase, it increases above 3. So we need to measure this to assess the degree of ovulation and the adequacy of the luteal phase, and we do this 1 week after the day of ovulation. It could be used to measure pituitary downregulation, but estradiol is more important. But today, the biggest role of measuring progesterone is to detect premature luteinization or a premature progesterone elevation on the day of trigger. So for confirming ovulation, we measure it 1 week after the presumed day of ovulation or 1 week before expected menses, and one value above 10 or three values above totaling 30 are adequate. For confirming pituitary downregulation, it should be below 0.5 on the second day of the period. But the main role is to detect premature luteinization, and it is here that the threshold value is below 1.5. So we now have significant evidence that if the progesterone is elevated before the trigger or on the day of the trigger, it has a negative impact on the endometrium because it induces early secretory changes in the endometrium and it lowers the pregnancy rates. So if you're doing an ovarian stimulation, then Dr. Jatin would have covered this, that if it is a fresh cycle, you should measure the serum progesterone on the day of the trigger. And if it is above 1.5, you should defer a fresh embryo transfer and freeze all the embryos and transfer them in a subsequent cycle. AMH is something which we had covered earlier. It primarily detects ovarian reserve, and there are many assays available, but today the assays of choice are the Generation 2 ELISA by Beckman Coulter or the automated Alexis from Roche. One should only use one of these two assays. As I mentioned, this is primarily secreted by the primordial, primary, and preantral follicles before they become FSH dependent. That is, before the stage of FSH dependence comes in. It can be decreased by BMI, ethnicity, vitamin D status, and polymorphism. It decreases with advancing age as the woman grows older. The spatial instructions, it can be measured on any day of the menstrual cycle. Any value below 0.7 nanogram suggests poor ovarian reserve. If you are measuring it in picomoles, then you multiply the value in nanogram by 7 and you get the values in picomole. So you measure this before starting treatment to offer appropriate treatment and to predict the starting dose. It is not very accurate in prognosticating success, but it does help in predicting ovarian response. So it can predict poor ovarian response and hyperovarian response much more accurately. Based on the AMH, you can stratify the treatment. If it is very high, you generally use a mild strategy, an antagonist cycle with an agonist trigger. If it is moderately high, you could use the antagonist with an HCG trigger. If it is normal, you can use the agonist long protocol. And if it is very low, you can use the flat agonist cycle. So this can help you in deciding which protocol to offer to which patient. And it is always seen in conjunction with the antral follicle count to decide the ovarian reserve status and the stimulation. We then move on to the last category of hormones, and these are the androgens. We have various sources for androgens. DHEA and DHEAs are of adrenal origin. Androstenedione is of ovarian origin, and testosterone is produced both by the adrenal and the ovary. Most of the circulating testosterone, however, is produced by the peripheral conversion of androstenedione to testosterone. And this helps in ovarian steroidogenesis, and I'll come to this when we talk about adjuvants. You need special instructions on collecting the blood sample for androgens. It is typically done early in the morning, and there are different normal ranges for each of this particular hormone. But when would you evaluate androgens in an infertile couple? One, if there is severe, rapidly progressing hirsutism, or when there are features of masculinization like clitoral hypertrophy, hoarseness of voice, or male pattern baldness. It is not used as a routine test in all infertile women. It could also be used to establish the cause of androgen excess, most importantly, late onset congenital adrenal hyperplasia or adrenal tumors. And sometimes, in cases of PCOS, when you want to look for biochemical evidence of hyperandrogenism. And in this, the free testosterone is elevated compared to others. So, which hormones to evaluate? TSH, yes, always. Prolactin, also a big yes. FSH, for those specific indications. LH, maybe. Estradiol, a big yes. AMH, yes. Antral follicles, obviously, and androgens also only in specific indications. With this, I'll now move on to the third part of my talk, where I'll talk about the role of various adjuvants in infertility. So an adjuvant is defined as a drug that helps or facilitates, such as this could be an ingredient that modifies the action of the principal ingredient, or it is an additional drug or a method that enhances the effectiveness of the treatment that is being used. And we shall be speaking more on the second aspect. And the adjuvants that I'll be talking about are this: antioxidants, aspirin, metformin, heparin, androgens, growth hormones, steroids, GCSF, PRP, and others. So let us start with the antioxidants. Now, reactive oxygen species, or ROS, is a cause for cellular damage and apoptosis. So it is believed that if you give the person antioxidants, it will reduce this ROS and it will hence reduce cell damage and apoptosis. This is based on very sound principles, but in practice, there is very insufficient evidence that both in men or women, this helps either in improving the sperm parameters or improving the oocyte quality. So very little evidence, but these are not uncommonly used. The second is aspirin, which is typically used in patients to improve both the ovarian and the endometrial blood flow by reducing vasoconstriction and in some way reducing platelet aggregation. And hence it is thought that it will improve endometrial receptivity. But let us see what is the evidence. The practice committee opinion from the American Society of Reproductive Medicine mentions that there is good evidence to recommend against the use of low dose aspirin to improve outcomes of ART. So very lack of evidence that supports the use. Same thing, eshregridines on recurrent pregnancy loss. Again, low dose aspirin is not recommended, except a patient who has a thrombotic disorder or has the antiphospholipid syndrome. But routine use of aspirin is not recommended. Now, metformin is an insulin sensitizing drug, which is thought to reduce androgen production and decrease the levels of insulin and insulin-like growth factors, which in turn helps stimulate FSH action. This high androgens may also affect the endometrial receptivity, and it is thought that in women with PCOS, this will help by improving the egg quality. But let us see what do the trials say. So this is a randomized placebo-controlled trial, which is looking at the role of metformin in an antagonist cycle, and it is thought that it does not really help in reducing OHSS. The third drug is, the fourth drug is heparin. Now this is used as an anticoagulant, and it is thought to act by reducing placental thrombosis and making the endometrial stroma resistant to oxidative damage. So this is primarily used for patients of two categories: repeated implantation failure or recurrent miscarriages. Now, there is plenty of evidence to support the use of heparin in patients who have established coagulation disorders or have a confirmed antiphospholipid syndrome. But what we are talking is of empirical use. And if you are using empirically in patients with recurrent IVF failure, the outcomes were similar. Then we move on to androgens. So androgenic agents like either testosterone or dehydroepiandrosterone have been used to augment follicular response in patients who have low ovarian reserve. It is thought that they will act on the androgen receptors in the preantral and antral follicles, increase the intraovarian androgens, which then get converted into estrogens and thereby increase the sensitivity of these follicles to FSH. But let us look at what is the evidence. Based on this particular study, a proof of principle double-blinded study, this mentioned that pre-treatment DHA supplementation did not improve the response to controlled ovarian hyperstimulation. In spite of a lot of evidence not in favor of it, a lot of physicians still use it in a dose of 25 milligrams 3 times a day for a period of three months. Using the same principle, a 1% testosterone gel is also used. Again, most of the studies are inadequately powered and not RCTs, so we still need more evidence to prove or disprove whether any form of androgens really help in improving poor ovarian reserve. If you look at the Cochrane database, in women with known poor responders, a pre-treatment with either DHEA or testosterone may be associated with live birth, but there is insufficient evidence to draw any conclusion. And the recommendation from the NICE guidelines again do not use DHEA. This then brings us to growth hormone, which is again thought to help by upregulating the synthesis of insulin-like growth factor 1 and likely to benefit poor responders. But if you look at the results of this RCT, it may increase the number of oocytes, but it does not improve the live birth rate. So again, the NICE guidelines do not use growth hormone as an adjuvant. What about steroids? Now, steroids are used for multiple purposes. One, it is thought that it increases follicular response, or it acts as an immunosuppressant if there is an immunological etiology for recurrent implantation failure. But again, if you look at the guidelines from the American Society of Reproductive Medicine, it mentions against the use of steroids during stimulation to improve outcomes. What about GCSF? This colonocyte stimulating factor is used because it is thought that it helps in endometrial remodeling and it improves the endometrial thickness. And this started with his first paper from Norman Gleicher, where he published a case study of 4 patients who were given this and it showed an improved outcome. But the moment we went into RCTs, the same author then later on concluded that even though this led to a minor increase in thickness, it did not help improve the live birth rates. Again, another RCT using GCSF and its role in endometrial thickness. Normal IVF patients, GCSF does not affect the endometrial thickness, implantation, or pregnancy rates. So most current evidence suggests that the use of GCSF does not help in improving ART outcomes. Even though no side effects have been reported, there have been some concerns raised about its complications with risk of myeloid neoplasms or sickle cell crisis or even increased bone pain. So it is not completely risk-free. So the again guideline from the American Society of Reproductive Medicine, there is insufficient evidence to recommend its use in IVF cycles. What about platelet-rich plasma? It is assumed that injecting this autologous platelet-rich plasma in women with diminished ovarian reserve or in women with implantation failure, it will help in improving either their ovarian function or their endometrial response. But there are very few trials, very few studies, and there is no evidence on its long-term use. This is one paper in Human Reproduction 2019 that this is a typical example of an add-on gaining widespread popularity based on a biological plausibility and mind-bending theoretical presumptions. And we should be extremely cautious prior to using this on a wide scale. So 2 cases of pregnancy, people have also used intrauterine HCGs. So there are multiple such drugs which have been used empirically, but none of them have shown to be of real benefit. One other area which really needs attention is the use of autologous stem cells in patients who have refractory Asherman syndrome. And this is a large pilot cohort study where patients' bone marrow stem cells were removed. They were concentrated, and under IITV guidance, they were injected into the spiral arterioles. Mind you, this is not intrauterine injections, but they were delivered into the spiral arterioles by catheterization, and this has shown promising results, but it is still very early days. Pentoxifylline, another substance used to improve the because it increases the red cell deformability, inhibits the inflammatory reaction, and it is again thought to improve the endometrial thickness. But again, few case studies, no control studies. Lastly, few studies have also looked at the role of vitamin C, vitamin E, and L-arginine, but very few poorly controlled studies. So for all the adjuvants, it is important to understand that we need to look at the harms and the benefits, because as doctors, our first aim is primum non nocere. First, do no harm. So except for a few drugs like aspirin or low molecular weight, the long-term side effects of all these drugs are unknown. Risks and side effects profiled with short-term use are also very poorly characterized. So hence, this should only be reserved for use in research settings in properly conducted clinical trials till we have evidences on their benefits or side effects. So with this, I would again like to thank you for inviting me and making me a part of this excellent webinar organized by the Iraqi Fertility Society and Intas Pharmaceutical. Thank you very much.
Thank you, sir, for giving a very good, very practical lecture and covering all the aspects of all the 3 topics and giving us the clarity. Our viewers also have benefited with this. We have reached the time, but and there are some questions, but I will be taking two or three. Sir, practically, when you are using low molecular weight heparin, they are asking what dosage and how do you use in which patients particularly?
So all the evidence suggests that low molecular weight heparin should only be used in patients who have recurrent pregnancy loss, either because of a hereditary thrombophilia which requires heparin, or who have the antiphospholipid syndrome. And in both these categories, heparin should be started from the day the pregnancy test is positive. It is used in conjunction with low dose aspirin and in a dose of 1 milligram per kilogram body weight every day. So this is the low molecular weight heparin, 1 milligram per kilogram body weight on a daily basis. This is typically continued till delivery, and all these women are also at a higher risk of thrombotic complications postpartum. So if required, therapy should be reinitiated once the immediate risk of postpartum hemorrhage subsides, and it should be continued throughout the postpartum syndrome phase.
They are also asking, sir, you already said that in empirically there is no role, but practically are they useful in recurrent implantation failure patients?
So no, so as far as recurrent implantation failure goes, none of these adjuvants has been shown to be of value. The two commonest reasons for recurrent implantation failure are a poor quality embryo, and by poor quality I mean a genetically abnormal embryo. So one possible testing is to do pre-implantation genetic testing aneuploidy screening, or it could be a poor endometrium which does not accept the embryos, endometrial receptivity problems, and this is where one should look at the endometrial receptivity array. So we should focus more on the egg or the embryo quality and on the endometrial receptivity rather than giving these empirical drugs.
The second question is for monitoring. You said that most of the monitoring is with sonography only, but with regard to estradiol, can you explain?
So estradiol monitoring really does not help very much because the range of normal estradiol values per follicle is very wide. And when you are doing controlled ovarian stimulation and you have multiple follicles, there is a wide range within which the estradiol would fall. So estradiol alone really does not help in predicting the ovarian response. What you see on ultrasound is the number of follicles. It is only in patients who are extremely poor responders. Maybe estradiol helps us in telling what would be the quality of oocytes. Does the estradiol level match the number of follicles? Or in patients who have borderline high follicles, where you want to take a decision as to whether to give her a HCG trigger or an agonist trigger and move into a freeze-all. Maybe at these two extremes, the estradiol level is of help. Otherwise, the ultrasound findings are much more reliable.
Uh, Sir, only one question, last question. Can you explain on subclinical hypothyroidism, means when to treat and when not?
So when a patient is planning a pregnancy, and if the TSH is in the range of between 2.5 to 5, this is more or less subclinical hypothyroidism, and you would like to treat her. If she was not planning a pregnancy, you would not have treated her. So any TSH between 2.5 to 5, you should treat with very low dose of levothyroxine. Maybe
Thank you,
12.5
sir.
microgram would suffice.
Right. So without taking your time, much time, so thank you, sir, for giving us time and giving us on all the subjects. You have covered all the practical points. And on behalf of Intaz and viewers, I thank you again. Once again, I will like to ask Dr. Salama if she wants to add on.
Thank you, Dr. Manish. It is very important and informative lectures. One question is about the DNA fragmentation test. Is it routinely for all male factor infertility or selective cases
So
for IVF?
I think this is still an evolving test. In again, as I mentioned, in theory, this is very good, but we have got four different assays. We have the tunnel assays, we have the SC assay. So there are four different assays, and the results are also not standardized. So currently, it is more in terms of research settings. It is more helpful in patients who have recurrent miscarriages rather than before routine IVF.
So recurrent miscarriages.
Yeah,
Okay.
that is where it has a bigger role. And if you find that the DNA fragmentation is very high in a patient with recurrent miscarriage, you have the options of giving long courses of antioxidants or to use spatial sperm selection methods like MAX or PIXI, or some evidence